Our first session begins this morning with Dr. Fink's presentation on drug holidays. Howard?
Okay, well, thank you for coming back. This is, I'm Howard Fink from the, anybody who wasn't here yesterday, from the Minneapolis VA and the Minnesota Evidence-Based Practice Center, and this is part 3 of our, from our evidence report. This session is on drug holidays. So my disclaimers are, again, the same as they were yesterday. This is based on a evidence report. We contracted with AHRQ. I have no financial interest to declare. And this is based on a peer-reviewed draft report. And in that regard, the draft report was posted publicly yesterday for public comment. And I think we're going to try to get the link up for people who are interested in providing constructive feedback so that we can make the final report even better. The goals of our systematic review are to review the evidence on the benefits and harms of long-term osteoporosis drug therapy and on osteoporosis drug treatment holidays and on factors that may modify these effects. This third part, we're talking about the drug holidays. So the key question for this part of the evidence report was among men and postmenopausal women aged 50 or older with osteoporosis or osteopenia, what are the benefits, and these are people who are being treated with osteoporosis drug therapy, what are the benefits and harms of drug holidays, and do the benefits and harms vary by patient, bone, or drug treatment characteristics? The methods are similar, largely the same as what I described yesterday for the long-term benefits and harms. We did an electronic search through June of 2018, references from systematic reviews. For the populations that we included were adults with past treatment here for osteoporosis or osteopenia to prevent fractures. In the drug holiday portion of the report, I'm talking about both the effects on fractures and harms. So for harms, we included participants regardless of their osteoporosis status. For our search, and we're talking about here, we defined drug holiday as people who had stopped their osteoporosis drug treatment for at least a year after prior treatment for at least a year. And again, we limited our scope to treatments that were FDA approved for treatment or prevention of osteoporosis. For effects on fractures, we limited our review to randomized controlled trials and controlled clinical trials. And for harms, we included both the trials and observational data. The efficacy outcomes are the same as yesterday, primarily incident clinical fractures, secondarily incident radiographic vertebral fractures, and third, change in BMD, but we are not addressing the change in BMD outcome in this presentation. Harms outcomes, same as yesterday, atypical femoral fractures with radiographic confirmation of AFF features, and then subtrochanteric or femoral shaft fractures which the radiographic features of AFF have not been confirmed, ONJ, serious adverse events. Possible effect modifiers, again, same approach as yesterday, patient, bone, and drug treatment characteristics. So the slides are organized by treatment, and so for alendronate, there were 2 studies that we thought provided some data on this. The first one was a study that enrolled individuals with they were all in postmenopausal women. They had enrolled patients with either osteopenia, osteoporosis, or just osteoporosis. The first study is the first two lines here. It's a complicated study, but the part that's relevant for the drug holiday question is the participants who'd had 5 years of alendronate were compared. They either had 2 more years of alendronate or placebo. This is a controlled clinical trial, not a randomized trial. And they found no difference between treatment groups in non-vertebral or clinical vertebral fracture. Then of the people who had 7 years of alendronate, they were either continued on alendronate or placebo, and in that comparison, there was no difference in non-vertebral fracture. The main study that provides evidence for this question, though, is the FIT long-term extension or FLEX study, in which participants who had received alendronate in FIT, either FIT 1 or FIT 2, and then continued on some during a gap between the end of FIT and the start of FLEX, so they'd been on it for an average of 5 years, were randomized to another 5 years of alendronate versus placebo. And the primary outcome was change in BMD, but they reported fracture outcomes, and this study found approximately a halving of the risk of incident clinical vertebral fractures. A hazard ratio of 0.45 that looked at other fractures, and there was no significant difference in risk of clinical fracture, non-vertebral fracture, hip fracture, or radiographic vertebral fracture. In looking to see whether the effects of treatment on risk of fracture varied as a function of other characteristics, patient characteristics, they evaluated both baseline radiographic vertebral fracture and baseline femoral neck BMD measured at the time people were randomized to placebo or another 5 years of alendronate, and found that the results didn't vary as a function of either of these factors. So for zolendronate, there are 2 studies. The first one randomized patients with postmenopausal women with osteopenia to zolendronate for 2 years versus zolendronate for 1 year, and then placebo for 1 year. They reported, again, the primary outcome was not incident fracture, it was a bone density change. They reported on clinical fracture. You can see the hazard ratio here is 1.37. The confidence intervals are very wide. So this didn't really provide sufficient evidence to draw any conclusions for this treatment comparison. Then there was the Horizon extension in which postmenopausal women who'd been assigned zoledronic acid for 3 years for having osteoporosis either by BMD or radiographic vertebral fracture were randomized either another 3 years of zoledronate or placebo. And what this study found was approximately 50% relative reduction of radiographic vertebral fracture and no significant difference in clinical vertebral fracture, which is the flip of the FLEX study. And then it was similar to the FLEX study in that it found no reduction in risk of any non-vertebral fracture, so no difference in risk of clinical fracture, non-vertebral fracture, or hip fracture. The people who had then 6 years of zoledronic acid, some of them were randomized to another 3 years versus placebo. It was a small number. And the hazard ratio for radiographic vertebral fracture was similar in magnitude, but there were few events. The confidence intervals were very wide. And there was no significant difference in risk between the treatment groups for clinical fracture. And these, with the small number of fracture and the wide confidence intervals, we felt that the evidence was insufficient to draw any conclusions about this treatment comparison, 6 years or 9 years versus 6 years. The study didn't report any information about whether differences in risk of fracture between continuing zoledronic acid versus drug holiday varied by patient, bone, or drug characteristics. There was a denosumab study that I talked about yesterday. I would have liked to have had this figure available to illustrate it yesterday, but basically it was a phase 2 trial in 365 postmenopausal women who had I think a T-score of -1.8 or worse. And it was a dose-finding study. There were 8 arms, essentially. 5 of them were different doses of denosumab continued for 4 years. There was an arm where denosumab was given for 2 years and then placebo for 2 years. What I have listed as arm 7, denosumab was 2 years, then placebo for a year, and denosumab for a year, and then finally the last arm was placebo for 8 years. This trial would have the possibility, if data were available, of providing some information about denosumab drug holiday effects, but it reported results only with all the arms in which somebody received denosumab pooled together and compared them to placebo, and did that for both fracture outcomes and harms. And so it wasn't possible to conclude anything about the effect of denosumab drug holiday from this what they reported. And then they reported no information about whether results differed as a function of patient, bone, or drug characteristics. So for harms, so that was the effect of drug holidays on efficacy, on fractures. So in this slide, I have the FLEX study results higher up on the table, but there were no significant differences between treatment groups in serious adverse events. There was just a statement, there were no data provided. The study reported no statistically significant difference between 10 years versus 5 years of alendronate in subtrochanteric or femoral shaft fractures, but you can see the confidence intervals are very wide, so very few cases, and so it's not really conclusive. ONJ, they reported that there were no cases. The study that looked at alendronate 5 years versus 7 years, and then 10 years versus 7 years, reported serious adverse events as being not statistically significantly different between treatment groups. For zoledronic acid, the study that compared 2 years versus 1 year of zoledronic acid reported that there was no difference in serious adverse events, but didn't provide any numerical data, and they reported that there were no cases of ONJ or atrial fibrillation. I believe they reported any information about AFF or subtrochanteric or femoral shaft fractures. In the Horizon extension, comparing 6 years versus 3 years, the Study reported no difference between treatment groups in serious adverse events, reported that there were no cases of AFF, one case of ONJ, and so not enough information to draw any conclusion about the difference in risk between the treatment groups. And for atrial fibrillation, it was, I think it was 3.4% versus 2.1% between the groups. It wasn't statistically significantly different, but numerically it looked like possibly more cases of atrial fibrillation in the continuation group. Then for the 9 years versus 6 years down here, again, no difference in serious adverse events between the treatment groups, no cases of AFF and ONJ during this 3-year follow-up period. And then for atrial fibrillation, again, well, the results were not statistically significantly different between the groups. Is 5% in the continuation group versus 1% in the discontinuation group. For denosumab, again, they reported that there were no cases of ONJ or atrial fibrillation in the study, and then didn't report data in a way that you could compare any outcomes between the denosumab continuation versus holiday groups. Looking at whether differences in risk of harms between osteoporosis drug treatment continuation and drug holiday differed as a function of patient bone and drug characteristics, we found no data reported. So limitations, the evidence on drug holiday. There were few trials. None of them had incident fracture as the primary outcome. The trials that existed had relatively few clinical fracture events, especially for hip fracture. No trials directly compared drug holidays of different durations and at the same time provided usable data. The trials were generally in healthy, largely white postmenopausal women without information provided on comorbidities. So the generalizability of the results to the population is unclear. There were no data on possible drug holiday effect modifiers. Ideally, though not everything here may be feasible, but with the future drug holiday studies should be powered to assess clinical fracture endpoints. It would be useful to have comparisons of different durations of drug holidays with or without restarting osteoporosis drug treatment, and including a continuous osteoporosis drug therapy comparison group. I mean, the particulars would vary depending on which agents we're talking about, but this is just a broader statement. It would be useful for studies to include high-risk non-osteoporotic populations, to include men, non-whites, and individuals with comorbidities. Harms data should be systematically and consistently reported, and the studies should specify factors in advance that to look at to see if treatment effects differ, to help individualize which patients may have a more or less favorable benefits to harms ratio for continuation versus drug holiday. And that's it.
Good morning, everyone. It's a real pleasure to be here. Thank you for coming out. I'm Dolores Schoback from the University of California, San Francisco, and I wanted to express my appreciation to Faye Chen and Lyndon for the opportunity to be here today. My topic is clinical perspectives regarding drug holidays following bisphosphonate therapy. I have one disclosure to make, and that's with one consultation with Radius Health in 2017. My presentation's been reviewed to ensure there's no bias, and we will not be discussing unlabeled use or any investigational products in this discussion. So I thought what I would do is frame this discussion over the next 20 minutes in terms of 3 typical patients that I often will encounter in my clinical practice. So the first is a 60-year-old female. You can see she had early menopause at the age of 42. She's taken weekly Residronate for the last 5 years. You can see her bone mineral density at initiation of therapy at the spine was negative 2.8, negative 2 at the hip. And currently, and the question is she a good candidate for a drug holiday? Her current BMD is negative 2.4 at the spine and negative 1.8 at the hip. My second patient for you to think about is a 66-year-old Asian female who had a radius fracture at the age of 60, trying to get onto the cable car in San Francisco. She's been on weekly alendronate for the past 5 years. Her initial bone density at the spine, negative 2.9, now it's negative 2.4. At the hip, negative 2.1, now it's negative 1.8. Then this third patient, 75 years old currently, when we saw her in the office, she'd reported 2 falls over the prior 18 months. At initiation of therapy at the age of 72, she'd had 1 mild and 1 moderate vertebral fracture confirmed on imaging. She's been on IV zoledronic acid yearly for the last 3 years. You can see her bone density, negative 3.2 at the spine, negative 2.7 at the hip, and negative 2.8 now after 3 years of therapy, negative 2.5 at the hip. And she's had no worsening of her baseline lumbar spine fractures and no new fractures in that time. So let's think about those 3 women as we go through these slides. So when I think in terms of clinical considerations for treatment interruption or a bisphosphonate drug holiday, and emphasizing that this is a treatment interruption and that patients need to be followed chronically, I like to update the current fracture risk profile clinically for that patient. And I'll refer you to the task force report on long-term bisphosphonates led by Dr. Adler, where a lot of this information is very nicely summarized. So I think about the current age of the patient. Was there a prior osteoporotic fracture when treatment was initiated, or did one occur while the patient was on therapy? I think about any new diagnoses that they've acquired in the time since they've been treated. Are they on new medications that are associated with bone loss now, like glucocorticoids or aromatase inhibitors and so forth? So what's going on with the patient? I like to have a current bone mineral density, particularly focusing on the hip sites in that particular individual. And then the patient characteristics, and I'm always thinking about that particular patient in view of the ones that seem to be at greatest risk for some of the rare complications that we've talked so much about in this conference. And then, of course, one needs to always think about and explore patient preferences. So when I think about the rare complication of atypical femur fractures, I always think back to these very important task force reports led by Dr. Shane in terms of thinking about who is that patient who's most at risk for this rare complication. And these task force reports looked at over 300 cases. And just some of the features that one gets from that is the median exposure was 7 years in these patients, but the range was really quite wide. Patients were at greater risk if they were receiving some other anti-resorptive during that time period. And then other medications, other comorbidities. Proton pump inhibitors are important, glucocorticoid therapy, being vitamin D deficient, being a diabetic. Rheumatoid arthritis, particularly if it's active, confers a very significant increased risk for these atypical femur fractures, and hypophosphatasia, of course. And then those who there was information on glucocorticoid use, you could see that the rate for these atypical fractures was quite high, and that adds, again, a very significant additional risk for that individual on long-term bisphosphonates, having been on glucocorticoids. These patients tended to be younger, under the age of 65. You can see that added some additional risk. And then which bisphosphonate they're taking. We didn't have information from that series on all of the patients, but we had it in about 189. And in those, the vast, vast majority had been on alendronate monotherapy prior to being reported with one of these fractures. Now, the Kaiser series, reported by Dr. Lowe in 2012 in Bone, included 38 women with atypical femur fractures. And in that series, 50% of them were Asian women, compared to the fact that only 12% of women over the age of 60 in the Kaiser Health Plan were Asian women. So certainly ethnicity figures into my thinking. And these patients tended to be younger, average age 74 for the AFFs in this series versus 81 for your typical hip fracture. So those are some of the characteristics that come to mind when I'm thinking about that rare risk, which is foremost, as you know, on the mind of our patients. I also think about the evidence for who might benefit from a longer course of therapy beyond that initial course, and as has been very nicely reviewed already. We think about the data from the FLEX study and data from the Horizon long-term extension. And again, we won't go into the details since this has been very well reviewed already. But what I think about there is that certainly from FLEX, they saw fewer clinical vertebral fractures in patients taking 10 years of therapy versus 5 years of therapy. So clinical vertebral fractures reduced, and morphometric vertebral fractures with 6 versus 3 years of zoledronic acid. So I'm thinking about that patient and that risk of vertebral fractures. Additionally, a number of subgroup analyses have been done on all of these data, looking at who is at highest risk and who might benefit from longer-term therapy. And the focus really has been on hip BMDT scores in both FLEX and Horizon. And when those get into the range of -2.5 or lower over time with longer therapy, there are fewer clinical vertebral fractures and fewer non-spine fractures in that highest risk group of patients. And as well in Horizon, fewer morphometric vertebral fractures. So that appears to be a high-risk clinical group of patients. Subgroup analyses have also looked at clinical characteristics. It's kind of try to figure out which group might be at greatest risk of fracture, considering a shorter term versus extended therapy. And in some of these analyses, the age over 75 or the weight less than 60 kilograms was actually not predictive. But the higher risk patient seemed to be those who'd had a major osteoporotic fracture that led to the initiation of therapy, and then patients who fractured while on therapy. And data from Horizon I've listed here. So if you had an incident vertebral fracture during the trial, that was, you can see, and here's the odds ratio, a predictor of having an additional new vertebral fracture during the discontinuation phase, 4 to 6 years of being on placebo, almost 5-fold greater risk. And if you had an incident non-vertebral fracture during the trial, again, that about 2 to 3-fold increased your risk of having a non-vertebral fracture during the 3 years of discontinuation. So in addition to those clinical characteristics, I like to think about which bisphosphonate the patient has been taking. I think that's an important consideration, and people have already mentioned that during this session. So alendronate, we know, has a tighter adherence or tighter affinity to the bone matrix, for example, than risedronate or bandronate, and so there's kind of a longer half-life, if you will, for its suppressive effects on bone mineral density and bone markers. And so in such individuals who've been on alendronate, one thinks maybe we can reassess after a drug holiday 2 to 3 years after the initiation of that holiday. If the patient's been on risedronate or abandronate instead, then that's a shorter, if you will, biologic half-life. So you might consider assessing that patient maybe at 1 to 2 years after the initiation of the drug holiday. And finally, with intravenous zoledronic acid, which we think has the longest half-life in bone, perhaps one might consider reassessing bone markers and bone mineral density maybe 3 years after the initiation of the holiday. And these are just rough numbers that one takes from the literature, not very data-driven, if you will, but at least this is a consideration in the clinical application, if you will, of a drug holiday. So with this background in mind, and there's not a lot of data in this area, as you can appreciate, I'll talk about 3 studies, 3 small clinical studies, and I've listed them here, as well as a cohort study out of Kaiser that Dr. Black has already mentioned to you. So this first one by Xu and colleagues reported on about 200 patients who were followed during a bisphosphonate drug holiday. And these patients on initiation of the holiday were 67 years old, as you can see. The mean BMI was 24. The treatment duration prior to the initiation of the holiday was 5 years, and patients were followed on average about 3 years after the initiation of the holiday. Everybody who got into this case study had osteoporosis at initiation of therapy, either by virtue of having a fracture or a T-score below -2.5, so they had the disease. And that you can see the breakdown in terms of alendronate versus risidronate, 150 on alendronate for 5.5 years, and 60 on risidronate for 4.5 years. And you can see the demographics down here. The majority, again, were Caucasian female with a few Asian women included here. So what they saw over time, and these are the bone mineral density results from the follow-up of these patients. Panel A is your lumbar spine bone density, panel B is the femoral neck bone density, and panel C is the total hip. And what they saw that bone mineral density over time did decline, and at the spine it was stable, and the femoral neck was stable for the first 2 years of the drug holiday. But then here at the 3-year time point, this was a statistically significant reduction in BMD at both the femoral neck and the spine. The hip, in contrast, fell significantly by the first year after the initiation of the drug holiday. And they really didn't find any clinical characteristics except for perhaps for the body mass index at the start of the holiday and a change in body weight that were significant predictors of the fall in BMD in these patients. They also they made a comparison between alendronate and risidronate in their population. And alendronate, again, this is the lumbar spine on your left and the total hip on your right. And alendronate is shown in the straight line, the non-broken line, and risidronate is in the dotted line shown here. And so I think what you can appreciate is that bone mineral density fell over time, particularly in patients who were on a holiday after being on risidronate therapy. It fell in a more negative direction in the spine and also fell in the total hip in a more negative direction. And the negative trends were statistically significant at both of these sites in patients on risidronate. This wasn't true for the femoral neck, but these two sites certainly was true. During the holiday, there were 22 out of the 208 patients, about 10%, that had a clinical fracture during the drug holiday, and you can see them listed here. 5 spine fractures, 4 wrist fractures, and these other sites were also included, 1 distal femur fracture. There were no hip fractures, no femoral neck fractures, and no atypical fractures in this clinical case series. And when they did a series of analyses, they could really not come up with any clinical, demographic, or BMD differences that allowed them to predict who were going to be those individuals who had fractured during therapy. But certainly I think this study is valuable for at least confirming our concerns that the change in bone mineral density with risidronate versus alendronate is probably going to be different. In the second study, 166 postmenopausal women with osteoporosis were followed for up to 3 years. In this study, all of them had taken 3 to 5 years of an initial first-line therapy. And you can see the therapies here, the majority on alendronate and risidronate and a few others on zoledronic acid and abandronate. Now, these were all initially treatment-naive patients that were placed on bisphosphonate, but they all were significantly osteoporotic, and about 50% had a fracture at baseline, so that this was a fairly high-risk patient population. Of the 166, 31 went on to a drug holiday, and the other 135, based on the decision by their clinician, continued therapy. And so over that 3-year period, there were 5 clinical fractures in the patients on the drug holiday, the 31, and 16 in the group that continued therapy. And you can see the percentage difference in patients who underwent drug holiday versus continued therapy. And after adjusting for all the variables that they chose to adjust for, there was about a 40% increase in the risk of having a fracture if you were a patient on a drug holiday in this study compared to those who continued bisphosphonate therapy. And when they expressed their data as the percent of patients without new fractures, and the blue were the continuous treatment group and the green were the drug holiday, you can see that being on a drug holiday raised your rate of having a new fracture. So the percentage without a new fracture was lower, and this was actually quite statistically significant. Of course, a study of this size has limitations, very small numbers, but in fact, it was the same clinicians that were making decisions about initiating the drug holiday in this entire group of patients, and the holiday was initiated consciously, which means it wasn't just a figment of being non-adherent, not filling the prescription, or other illnesses changing the overall clinical outlook for a patient that led to their coming off therapy. They further looked at the FRAX scores in these patients, and FRAX wasn't predictive of who was going to fracture. But the best predictor, in fact, in this study was actually the age of the patient. And those who fractured averaged age 71 versus those who did not, average age 65 and a half or so. So age turned out to be an important clinical characteristic in this small study. And the final small study to tell you about is one with 134 patients in it, 10% of them being men, who initiated a holiday after about 6 years of bisphosphonate therapy. And the plan in this study was to do follow-up at 12 to 18 months after the holiday and 24 to 30 months after the initiation of the drug holiday. And roughly the guidelines by NOG were followed by the clinicians in this study, deciding who and when to discontinue bisphosphonate therapy in. And I'll point out to you that these were not particularly low-risk patients. So 55% of the ones on oral bisphosphonates had had a prior fracture, and of those on IV bisphosphonates, almost 75% with a prior fracture. So not a particularly low-risk group, a high-risk group, if you will. There were some men in here, as I've already said, and about 30% of the individuals here had some form of secondary osteoporosis. And you can see 97 on oral bisphosphonates, 37 on IV bisphosphonates, with a treatment duration here of 6.5 years for the orals and about 3.5 years for the IV bisphosphonates. So what happened over time? So again, the first time point for making a BMD measurement was 12 to 18 months, and that's shown in the white bars for the spine, the total hip, and the femoral neck. And at this very early time point, these changes in spine bone density, but particularly at the hip, about 1.5 to 2% decrements in the hip bone mineral density at this early time point. And based on that, again, this was clinical decisions drove this study. Patients, 42% of them were restarted on their bisphosphonate therapy. In those that continued on the drug holiday, you can see 2.5 to 3% changes at the femoral neck and the total hip at the 2 and 2.5 year time point after the drug holiday. So they also looked at bone turnover markers, serum CTX and serum P1NP, and at the 1 year time point, there was about a 90% increase in CTX and about a 90% increase in P1NP in these patients, and those changes persisted at the second time point of measurement, which was 2 to 2.5 years. They didn't see differences between having been on oral bisphosphonates versus IV bisphosphonates in the marker changes, and they saw no correlation between the changes in the markers and the BMD changes in this population. And they also did one other, I think, interesting thing, which was to calculate FRAX scores. And so at the 12 to 18 month time point, those in whom they felt they needed to reinitiate therapy on clinical grounds had a major osteoporotic fracture risk for 10 years of 21%, and at the hip of almost 8%. And those who continued the holiday, those numbers were lower. And they also looked at FRAX scores over 25% and under 25%, that's shown here, and the rate of femoral neck bone loss. And it was almost 3.7% in this 12 to 18 month time point if your FRAX score was over 25. And it was quite a bit lower. It didn't quite make statistical significance, but it was quite a bit lower if your FRAX score was under 25. And these are the 3 fractures that were reported during that study. So the conclusion of these authors was that experience in clinical practice is quite different from clinical trial experience. And the final study, just to quickly summarize to you, is a retrospective cohort study developed out of the Kaiser data set on almost 40,000 women. And Dr. Black has already introduced this study to you. But these women received bisphosphonates for on average 5 years, and you can see the vast majority received alendronate. And when they looked at this group of almost 40,000 women, they broke them down into those who had taken a drug holiday, and that was defined as over 12 months off therapy, those that were persistent users, and they defined that as 50% or better adherence, and then non-persistent users, less than 50% adherence. And so in this cohort study, the average drug holiday, you can see, was 3 years, and they had plenty of fractures that occurred during that time to examine. And so in the patients on the drug holiday from this big cohort, they saw no differences in fracture risk in the holiday patients versus the persistent user. Here's the hazard ratio. And they saw no difference in hip fracture risk. Here's the hazard ratio. And vertebral fracture risk actually might have even been slightly lower, but certainly these patients on the drug holiday on the basis of this study were okay. They were protected from harm, particularly compared to the non-persistent user. So with the data that I've reviewed and the thoughts that I've put forward here, let's come back to these 3 women. The 60-year-old with the early menopause and 5 years of residronate therapy, who's had an improvement in her BMD. Am I going to initiate a drug holiday? I think yes, and with the residronate, I'm probably going to do yearly clinical follow-up and probably a BMD at the 1-year time point. In my 66-year-old Asian female with the radius fracture, 5 years of alendronate, who's improved her BMD, I think I'm going to initiate a drug holiday here, do yearly follow-up, and perhaps a BMD at the 2-year time point, although this is all up to clinical judgment. Now to my 75-year-old woman reporting some falls and quite significant spinal disease, who's had an improvement in her BMD after 3 years of zoledronic acid. What am I going to do here? Well, she's 75 years old. She's falling. She has prevalent vertebral fractures, and her hip bone density is still in that negative 2.5 range. So for her, I'm thinking I'm going to continue treatment. I'm probably going to continue treatment with IV zoledronic acid, but we have little guidance as to whether there might be some other therapy that might be better for someone like her. But I feel that with enough clinical risk factors, I would continue therapy. So if I can summarize the evidence I've reviewed with you, BMD of femoral neck and total hip, negative 2.5 or lower at the end of an initial treatment course, seems like a good marker for postmenopausal women who are at greater risk during a treatment interruption or a drug holiday. Women in the older age group, I'd put this at age greater than 70. This may identify them as a group to be cautious about in initiating a drug holiday, although the data are somewhat inconsistent. We have no guidelines currently on how to manage this treatment interruption. Who's the right patient? What's the right duration? How should risk factors be weighed in our decision making, and how we should monitor them? And finally, in practice, the consequences to a treatment interruption are very individual, and patients really need to be counseled individually. Bone density may be lost during that time, and fractures may occur. So some key recommendations that I would make: I think it would be extremely valuable to have more real-world experience. And I'd love to see a program that prospectively assesses treatment interruption in real-world clinical settings, looking at BMD, looking at markers, looking at clinical characteristics, FRAX scores, anything that we can use at the point of care to help us make these decisions. I think it would be great if we knew when to use anabolic therapy. When is the right time to introduce it in a patient that we're looking at the long-term sequence of care? And then finally, I think it would be critical to close the gender gap and certainly the ethnicity gap. We need to have sufficient numbers of men with osteoporosis in these studies to really better understand the consequences of drug holidays in men. And so with that, I'll close and thank you for your attention.
Good morning, everybody, and I'm grateful for the invitation to come and present here. My name is Richard Eastle, and I'm from the University of Sheffield, where I'm the director of the Mellonby Centre for Bone Research. And my topic this morning concerns tools to guide decisions regarding long-term treatment. So over the past day or so, we've heard about individualizing treatment and personalized medicine, and hopefully that's what I'll get to. So these are the disclosures that I have about my consultancies and grant funding from IDS, Roche, and Nitobo. And I'll not talk about unlabeled use of products. So these are the summary of my findings, and they're going to be concerning bone turnover markers, bone mineral density, and spine imaging. And I'm going to be pointing out that bone markers can be used to identify response in the individual patient to treatment and allow us to study the offset in individuals. And bone density useful in identifying when patients have reached a goal and when they're ready for a drug holiday. And spine imaging useful for identifying those patients who should switch treatments and people in whom we should avoid a drug holiday. So the three main tools then: bone turnover markers, bone mineral density, and vertebral fracture assessment. And we have a number of decisions we have to make when we're treating patients in the long term. And I've put 4 of these decisions just here. But the important thing I want to make is that when we're thinking about the individual and n equals 1, we need to have the statistics that are appropriate to individual patients. And so I'm going to be talking particularly about the least significant change and also about the use of thresholds. And by using these, we can then identify people who do and don't respond to our treatments. So my first section then, I'm going to talk about bone turnover markers and how these might be used. And so with the bone turnover markers, there are a number of them, but the International Osteoporosis Foundation recommended that we focus as reference markers of the bone resorption marker CTX, or CT-lipeptide, and the bone formation marker procollagen-1 N-propeptide, so CTX and P1NP. And so much of my talk, I will do that. And in order to use bone turnover markers, then we need to know about the sources of variability. And these are listed here as proposed by the NBHA in our recent review of these sources. So when we say controllable, we mean the physician can control them. And so knowing about the circadian rhythm means that we can take the sample for a bone resorption marker first thing in the morning. Similarly, when we have uncontrollable causes, like age and gender, we can make sure that we use reference ranges which are appropriate to a person's age and gender. Now, people have proposed a number of uses of bone turnover marker, and I'm listing some of them here. They can be used for risk assessment, in that it's the case that higher bone turnover in the older person is associated with higher rates of bone loss and of fracture risk. But today I'm going to focus much more on treatment effects and monitoring this, monitoring the response and monitoring the offset. Now, I could talk about all of the anti-resorptive treatments, but I don't have time. And because the most common treatment that we use in clinical practice are oral bisphosphonates, I'm going to focus on these. I could have talked about parenteral anti-resorptive therapies, and I could also have talked about anabolic drugs, but the principles I'm going to enunciate will actually be applicable in the main to these treatments too. So we designed a study about 10 years ago that we call the TRIO study. And it was going to be comparing the 3 commonly used oral bisphosphonates at their licensed doses. So ibandronate, alendronate, and risedronate. But the trial wasn't to see their relative efficacy. It was to see how we could use tools like bone density and bone turnover markers to monitor the individual patient. So we designed the trial so that we could do that. So we were looking at bone turnover markers and bone density. We recruited women with postmenopausal osteoporosis. But in the trial, we had replicate measurements of bone turnover markers and bone density so that we could calculate the biological variability, which allows us to estimate the least significant change. We also recruited a group of healthy young women so that we could have a reference range. So that allows us to take our 2 approaches that we're going to be using for identifying response. And this is the baseline data from that TRIO study, just showing these 172 postmenopausal women with the bone resorption marker CTX. And I want to make 2 points here. The first one relates to the reference interval. So when we look at the reference interval shown in blue from these healthy young women, you'll notice that the average value isn't in the middle, it's towards the lower end because the distribution is skewed. So this is our geometric mean for healthy young women. And you can see that with osteoporosis, almost nobody falls below that. 95% or more are above it. So they're either in the upper half of the reference range or they're high. Now, we said earlier on that higher bone turnover markers is associated with faster bone loss and fracture. So these people probably are more at risk of these things. And they also tend to respond better to anti-resorptive treatment. And when they stop treatment, if they're on the drug holiday, they tend to bounce back quicker. So I'm going to come back to this concept of the geometric mean in a few minutes. Now, what happens when we give the oral bisphosphonates? And I'm showing here alendronate, since that's the one that's most commonly used nowadays in most countries. And I'm showing you 2 bone resorption markers, serum CTX and urine NTX, to make the point that the change is very large and it's very early. So by 12 weeks, the maximum responses occurred and will stay down, the CTX will stay down there for as many years as you give the drug. And also you can see that this is a standard error, but it's much less than it is for the urine marker, the NTX. So the CTX, it emphasizes the value of this marker for monitoring therapy and being able to do so at the very early time point. Now, bone formation markers, they show the same pattern with one exception, and that is for the first 4 weeks, there's no change. But then after that, by 12 weeks, we almost have maximum suppression, with the P1NP showing the greatest reduction. So we have here a paradox that some people find difficult to understand, that actually bone formation goes down when you give a drug that benefits bone. But it means that it is a useful marker for identifying response. Now, later this morning, Dr. Bauer is going to talk all about the FNIH study. But I wanted to show this to make the point that actually when you do have the greater reduction in bone turnover, as shown here or here with P1NP, then you have the lowest risk of having a vertebral fracture, as we've published. So it does seem that the bone turnover marker response is relevant to their fracture benefit. But I want to focus on the individual, and so here I'm showing you the least significant change concept. And this has been used in the 30 or so years that we've had DEXA. This has been used to identify whether patients are responding to treatment. So here we're showing lumbar spine bone density. In the TRIO study, we had replicate measurements of bone density, so we get the biological variability, and we can calculate the least significant change, which is the likelihood of somebody exceeding the usual variability at p less than 0.05. So it's about 4% in this study. And so you can see the average person given alendronate would have about a 4% increase by the 48-week time point and about 6% at the 96 weeks time point. So about 2/3 of the people at 2 years would be responders, whereas P1NP, the response is much, much greater and much earlier. So by 12 weeks, as we'll see in a moment, about 90% of people are responding. So one of the advantages of using bone turnover markers is that the response is large and it's early. And least significant change isn't something which just the bone community use. In the field of laboratory medicine and clinical chemistry, it's widely used. It's just called something different. It's called reference change value in that particular field. And so in the TRIO study, when we look at the 3 different bisphosphonates, alendronate, risedronate, ibandronate, and we put in the threshold for least significant change for CTX, we can see that just about everybody responded. And we had adherence information on all these patients. We had MEMS caps, which are electronic caps that allow you to calculate adherence. And these people were pretty adherent. So they're pretty adherent and they're pretty responsive. And it wasn't quite the same with risedronate, but risedronate's a less potent bisphosphonate. So we wouldn't expect such a high response rate, whereas it's about 80% for risedronate, whereas it's 98% for the alendronate. So this information means that actually if people are adherent, they're very likely to respond if they're getting alendronate and you measure CTX. We did the same thing with P1NP because it too goes down, and P1NP has the advantage that we don't have to measure it in the fasting state, and it's less variable. And so again, we have the threshold here. So again, most people are responders with alendronate, but now it's more like 80% rather than 90%. So this information has been used by the International Osteoporosis Foundation as a way of identifying patients who are not responding to treatment for whatever reason, particularly poor adherence. So when the IOF put out its poor adherence guideline, then they proposed that we should measure bone turnover markers at the start of treatment, and then again 3 months later. And if the bone marker exceeds the least significant change, then probably something good has happened and we can continue the treatment. And if it hasn't exceeded that, then we should reassess what's happening. Usually it's the adherence that's poor, and we should reinforce the importance of taking the medicine correctly. Now, we don't always have a baseline bone turnover marker. Quite often the patient's sent to us when they're already on treatment. And so we need to have an alternative approach to identifying response. So the alternative approach that we've proposed is that here I'm showing the CTX in the TRIO study, and pointing out, as I showed you earlier, that if we have the geometric mean for healthy young women here, just about everybody with osteoporosis is above that, whereas when they get alendronate by 12 weeks, just about everybody is below that. So knowing whether the person's above or below the geometric mean is a very good way of knowing whether they're taking the medicine or not. And so if we talk about responders, then it would mean we could identify 96% of people as responders in this way. And the P1NP is a similar value. So much for bone turnover markers from the TRIO study. This meant that we've taken this data and we've applied this in clinical practice, and we tell the general practitioners, the primary care doctors, to have 2 targets. One is the greater than least significant change, which is the statistical approach that I've described, and we can below the mean for healthy young women, which is the biological value. And we found it useful to give the bone marker change in absolute units because that's easier to manage in general practice. So we've implemented this and we use it on a regular basis. But what happens when you stop treatment? And so we've heard already from Dolores some trials which are observational. Ours is a randomized trial because, of course, the TRIO study, people were randomized to the 3 bisphosphonates. So we don't have the bias that you usually put risedronate onto milder cases of osteoporosis. Ours were all randomized at baseline. So 57 of the women, after the 2 years of being given the drug, they met the criteria of stopping because their femoral neck BMDT score was above -2.5. So at this point, we stopped the drug. And so you can see that risedronate, ibandronate, and alendronate, they all resolved. And within the first 6 months, we saw quite a lot of resolution of the bone turnover, not back to baseline, but towards baseline, perhaps half resolution. But by the end of the 2 years off, all 3 bisphosphonates are pretty much the same. And the same is true for the bone formation markers. By the end of the 2 years offset, all are the same. So the idea that the drugs might be different, I think, was a misconception based on theoretical grounds. But when we do the randomized trial, they're all the same. So we can use the markers to monitor offset, and we need to do more research on this because there isn't very much looking at individuals. But my proposal is that we should do the same approach that we do for onset of treatment. We should use the least significant change approach, and we should see whether patients exceed the threshold. So this is an active area of research at the moment. So here I summarize bone turnover markers as a tool for long-term therapy and how they might be used, what the strengths are and what the limitations are. So I won't read through all these because I've just spoken them all, and you can read faster than I can talk. So I'm going to move now from bone turnover markers, and I'm going to go on to the next topic, which is bone mineral density. So here we're asking questions about whether treatment should be stopped, whether drug holidays should be terminated. So bone density, the test has been around for about 30 years now, the DEXA test, and it's worldwide it's used as the test for diagnosing osteoporosis and usually for making decisions about whether we start treatment. So very important test. Today I'm going to be talking about how it might be used to identify whether a change in therapy might be required or whether we should be stopping treatment or restarting after a drug holiday. And I'll use some similar concepts of least significant change and thresholds that I've used for bone turnover markers. So when it comes to thresholds, one of the exciting ideas of the last few years is that we should learn from other therapeutic areas and use a goal for treatment for bone density, which seems to me possible. And so this is Mike Lewicki writing about this topic. And he was comparing the current paradigm of how we manage osteoporosis with if we were to use a treat-to-target paradigm. And so some things are just the same, but other things are different. So you might choose your treatment based on will you be able to reach your desirable level of bone density. So whereas with the current paradigm, you might give everybody an oral bisphosphonate. If you have somebody with very low bone density to begin with, you might start off with a more potent drug like denosumab or teriparatide. So this approach does lead to different forms of practice. And similarly, when you're looking to see whether or not you've had a good success, then you need to attain a particular value, which might be a T of, let's say, minus 2.5. And if you don't reach that target, then you have to make a change to your treatment. Whereas with the current paradigm, we're just interested in changing bone turnover to beyond the least significant change. So this is a kind of change of way of thinking about how we might manage the disorder using the goal of therapy approach. Now, we've already heard about Dr. Adler's review from the ASBMR about when we should begin a drug holiday, and how bone density really can be so useful in making that decision. And so this is based on the two key trials, the FLEX trial and the Horizon trial. So in making the decision whether a person who's had 5 years of oral bisphosphonate or 3 years of intravenous bisphosphonate, we take into account whether the bone density of the hip is above or below minus 2.5, and whether there's a high fracture risk, and whether they've had a fracture or not. So if they've not had a fracture in the first 3 to 5 years, and if their bone density is above minus 2.5, that's when we consider a drug holiday. So that's a really good use then for the bone density test in this particular setting. What about using bone density for the drug holiday about when it should stop? And so we looked at this in the FLEX study, and here I'm showing the distribution of the most reliable total bone density measurement in the older person, namely total hip. And I'm putting in the estimate of least significant change from the IOF's report, just illustrating that even after 5 years of stopping alendronate, only relatively about a third of the people would actually exceed the least significant change and be considered a fast loser. Whereas with the bone turnover markers, even after the first 6 months, about a third of the people can be seen to be exceeding the threshold for perhaps restarting treatment. So I don't think bone density is such a good way of monitoring, but we don't know, and so that needs to be further investigated. So when it comes to thinking about bone density as a tool, it has its strengths, it has its limitations, and I've listed those here, that really it's a very useful test, and it can help us to make some decisions. Now, those are my two major tools that I use in clinical practice, but my third tool, I can't possibly leave without saying a little bit about it. But the third tool is identifying vertebral fractures, and this is going to be talked about more in the next presentation with Dr. Miller. But just to make the point that it is a really, really important part of our practice to identify vertebral fractures because they're so often they're asymptomatic. And so the ISCD came up with guidelines when we should be doing imaging of the spine to identify vertebral fractures. And I've spent the last 35 years of my career trying to work out how you should spot a fracture. And this is finally the algorithm that we came up with, which we think is the best way of identifying vertebral fractures. And in this algorithm, which we call the algorithm-based qualitative approach, we identify vertebral fractures, osteoporotic vertebral fractures, or vertebrae as being normal, or non-fracture deformity. And so we've spent years working out this algorithm. We now have training courses where we teach people how to recognize vertebral fracture, because this is such an important part of what we do. But automating this approach is an area for the research agenda, because we need to be able to do this in a widespread way. So I'm summarizing here what are the strengths and what are the limitations of vertebral fracture analysis. We use our DEXA machine usually. We can use regular radiographs. And of course, we can reconstruct the CT image or MRI to spot vertebral fractures. So these are all approaches that we can use, and is proven to be a very useful tool in our everyday work. So what are the research gaps? So when it comes to bone turnover markers, then we need to have more information about the effects of stopping treatment. And we need to have more analyses around least significant change in thresholds. And we need to have the bigger studies. Bone density, maybe we should be also evaluating further other tests besides DEXA, like QCT. And imaging, we need to automate the approaches. So my recommendations that we need to characterize better the changes in bone turnover markers after stopping licensed treatments. We need to relate these changes to harm. What's the relationship between bone turnover on treatment and harms such as AFF? The relationship between bone markers during a drug holiday and changes in BMD and fracture risk. And finally, other approaches to spine imaging like CT. So with that, I shall stop. Thank you very much.
We're going to have a brief discussion section here going into the next session, which starts at 10:15, before we have a break later in the morning. So as we did yesterday, we start with questions from the panel.
Thank you. So given the relative dearth of information that we have about drug holidays coming from very few clinical trials, and going back to a conversation from yesterday about whether it's reasonable to expect long-term trials, 10 years or more, for osteoporosis ODT. Is it reasonable to expect that we will be able to learn anything about or understand anything about appropriate length or initiation of drug holidays from these extended trials, or do we need to be thinking about alternative sources of information about drug holiday or other study designs, and what might those look like? A few more seconds.
Well, just to comment on that, because I've thought a lot about this, and it's these studies are extremely hard. You saw my study was 2 years plus 2 years, and I'd love to have done 5 years plus 5 years, but eventually I'm going to retire. And the trials are just so long, and also one of the challenges about doing trials is the state of equipoise. And so when you get to starting and stopping treatments, patients often have quite a strong opinion, and so recruiting patients to a trial is often quite challenging. So doing further trials is actually quite challenging in this area. But there are opportunities of taking the data from the FLEGS, from the Horizon and so forth, analyzing that to answer some of the questions about can we monitor the individual, for example. And there are opportunities of looking at registers and looking at bone density change in people who have stopped treatment, just like Dolores had spoken about. So there are further opportunities for getting information. But starting off new trials is a bit of a challenge.
Thank you for your presentations. Again, I learned quite a bit. One of the things that might be helpful is if you could say something about how these different ODTs may vary on different bones in the body, because we see a lot of evidence about vertebrae, some about hip, but Dr. Schoback showed us things where there was ankles and feet and wrists, and we don't hear a lot about that. So might you say something about why these therapies may work better in certain bones than others, or something along that line, so we could understand the differences?
I have a little go, and is that right? Yep.
Go ahead.
All I was going to say was when we see the bone turnover markers come up, then often the fracture that bone turnover markers relate to most strongly is vertebral fracture. So in the trials that we heard from, particularly earlier on, the Flex and the Horizon, when we saw the fracture that really made a difference if you continue treatment was vertebral fracture. So that doesn't surprise me at all, because vertebral fracture is very sensitive to changes in bone turnover. So I think there are very much differences depending on which fracture type, but it's vertebral fracture versus all the rest. Vertebral fracture is the classical fracture that goes along with higher bone turnover, and therefore, so we do see differences between the different fracture types, and that's the major distinction in my mind.
I'll make one comment on that, which is that certainly we know that spinal bone density, because of the type of bone that's there, is more responsive to the typical therapies we're talking about, bisphosphonates and anti-resorptive therapies. You see the biggest changes in BMD, the most rapid change in fracture reduction, and so forth. In the studies that I presented and tried to review here, really no one had systematically. They collected clinical fractures as patient-reported outcomes and adverse events, so to speak, but really vertebral fractures, morphometric, were not looked for specifically, and we know that what we see clinically is a very small top of the iceberg, and there's a lot more that goes on there. So really the real-world clinical experience with other fracture types, particularly vertebral, that are radiographic, we have very little information about, except from the extension trials that have been done.
So I have a question about the bone, the turnover. And it seems like bone mineral density is, as you said, that the majority of people after 5 years, you see a lot less change and you see the turnover a lot faster. And so I was just wondering if, when you're trying to weigh both the factors of the turnover versus mineral density, given the different time courses, is the turnover more right now in kind of the research stage, where the BMD is more of the kind of clinical practice stage? Do you see that, or do you see the turnover being used more and more in the clinical decisions?
Yeah. So bone turnover markers are used in a patchy way. So we use them all the time, and I have done for the last 20 years, but not all physicians use them. And it's partly because not all physicians feel comfortable about this issue about variability and being able to control for that. And it's partly because in this country, bone markers are far more expensive than elsewhere. You pay about 10 times more for your bone markers than I do in my practice. So for me, it's very easy to use them. And of course, these drugs that we were using, the primary way in which they're working is through the cell and through changing the cellular activity. So when we're measuring bone turnover markers, whether it's resorption or formation, we're observing the primary effect. And when we're looking at the bone density, it's a secondary effect. And so when I was saying that when they have the offset period, we see early changes in bone markers and later changes in BMD, that's just what we'd expect, is that they occur earlier. So if the question is, in my patient, has the bisphosphonate worn off, you'll pick it up earlier if you measure the bone markers. So that's an advantage. So they're both good tests. It's just that if you want an early signal, the bone markers tell you easily.
It would be fair to say, however, though, in the U.S., for example, the use of these turnover markers in actual practice is very, very low, for the reasons that Richard has talked about, and the CTX, which may be the most sensitive, needs to be collected under conditions, as he described, fasting and first thing in the morning, and it's a bit inconvenient. So the uptake has not been huge.
Dr. Fink, you were sharing with us a review where you were looking at showing a test of differences among people who had some sort of cessation or drug holiday. Can you give us your point of view on whether you really want to test for differences or you want to test for equivalencies?
I guess that's really a clinical question. What we were reporting in the evidence report is the results that the primary studies reported, and I don't recall that they statistically looked to see whether the results were equivalent, that they were designed as equivalency studies. I think that they were designed to look to see whether the results on fracture outcomes differed between the two treatment assignments. But if you were just looking to see whether, you could ask that question, whether the risk of fracture stayed the same even after you stopped treatment.
And so I'd like to ask the clinicians, are your patients asking you, will it be the same if I take a break? Or are they asking if it's going to be different?
Yeah, so I see your point, actually. I was part of the clinical trials which you were talking about in terms of being an investigator. So we did test whether they were different, as Howard just said. But you could argue that the patient would want to know, I've got two choices here, I can stop or I can keep going. Is it going to be the same? Seems to me like a reasonable question. Yep.
And just to follow up on that, I'm just curious in terms of the patient, when they are on this drug holiday, are there any typical side effects? I mean, given that they're coming off a drug, are there, I don't know, headaches, diarrhea, or anything like that a patient would undergo?
No, they're happy to be relieved of having to take the medicine for a few years, usually. And but I've not seen anybody complaining of anything, because to be honest, these drugs, like especially the oral bisphosphonates, are really safe. We've talked a lot about all of the challenges you get in terms of atypical fracture, but these are all really, really, really rare. So most patients we see, they're usually pretty happy with the medicines that they're taking. So when they stop them, they're also pretty happy. So it's actually very rare to encounter any problems.
Good. Let me open this to questions from the audience. And why don't we start over here?
SAG UAB. Howard, thanks again for another excellent update on the meta-analysis. The clinical question that really is on everybody's mind right now, and in fact is approaching the bisphosphonate drug holiday issue, is what to do with long-term denosumab. And you provided a little bit of data on that. I'm wondering, though, if your meta-analysis included a recent paper published by Steve Cummings in JBMR that showed an increase in fractures after stopping denosumab and had a trend towards an increase in multiple fractures. This has really been a very important paper that's influencing practice these days.
Is this the study with a virtual control group?
No, actually, they had a control. Yeah.
No, it wasn't
it's an ad hoc from
It was
Freedom.
in the Freedom trial, because I was a co-author on the paper. In the Freedom trial, we had a number of people who actually stopped the treatment but were followed. Stopped the denosumab and they were followed for an average of about 7 months. And so we looked at their fracture rates. And we reported that just in the Journal of Bone Mineral Research just recently, in the last few months.
Okay. Well, I think I've heard of heard of this study, but so was this published after June?
I can't tell you the number.
Okay. Well, I'll look it up. You know, read. But.
The evidence reports in comment period, so I think this is, good thing to bring up. Question?
Hi, Doug Bauer from San Francisco. So for the panel member that was asking about the use of bone turnover markers in the U.S., I just wanted to add a quick comment to Dr. Stell's really beautiful presentation, which is we have another problem here besides the really exorbitant costs, and that is at least one of the markers cannot be measured on an automated platform, which is P1NP. The FDA has only approved the immunoassay here and not the much more reproducible platform-based assay. So that is one problem. The other problem is that for primary care doctors like me, when I send off a bone turnover marker, I actually don't know where it goes. My hospital sends it out to the lowest commercial lab with the lowest price, and we've just done a comparability study where we sent blinded specimens to 5 commercial labs, and even with CTX, there was a lot of variability between commercial labs. So I'm very optimistic and hopeful, but there's still some kinks to be worked out in the U.S.
So I sympathize with everything you say, Doug. One thing we are trying to do through a committee of the IOF is to standardize and harmonize the bone density testing, whether it's CTX or P1NP, and we're in the process, but it all takes time, and I appreciate all of the points you're making.
Rob Blank, Wisconsin. This is directed primarily to Dr. Eastle. And I would like to follow up on the concept of least significant change, both for turnover markers and for DEXA. And the challenge that exists is that a lot of patients change facilities, and there is no comparable way to measure least significant change if you're going to a different facility. Can you comment first on inter-site least significant change with markers, and second, what you might propose? Have you thought about the possibility of research needs in terms of establishing a cross-facility kind of DEXA least significant change? And following up on that also, there is a big issue in the United States in terms of the quality of DEXA performance. So there is extreme variability. I can tell you from my own practice, and I'm sure others can echo this, that we get referrals of patients who have very poor quality DEXA studies done ahead of time. In our academic centers, we do better, but not necessarily well. And this, too, is a challenge to using the tools effectively.
Thank you very much for that. So there's several components to your question there. The first one is this issue about least significant change for bone turnover markers. So interestingly, almost all the variability, let's say 80 or 90% of the variability, is within the person rather than within the assay. Because nowadays, when we measure bone turnover markers, we do use the automated analyzers, and the CV of the assay is run about 2%. So it's really small, whereas the person, within the subject, is more like 10 or 15%. And so it's a much bigger component. So therefore, it doesn't really matter whether you make the bone turnover measurement or whether I make it. It'll have the similar least significant change. Now, DEXA, I appreciate, is different because then there's a lot of the operator, there's a component, rather, of the operator where it really does kind of contribute to the overall. So there is a challenge, and I appreciate that. There is another aspect about least significant change, which is we all of us have a different LSC. We could actually calculate an LSC for you and for me, and actually it'll be different because some people are variable people, and some people are very steady, and probably it relates to the way we live. So there are some complexities to least significant change, which I kind of glossed over in giving my talk, and I'll be happy to speak to you more about.
So one more question, which is, can you tell us whether there is any research ongoing right now, because I believe it's a need, and it's alluded to by Dr. Adler's talk yesterday, of developing markers for post-translational modifications of proteins such as advanced glycation changes that happen with duration of residence in the tissue that might be useful in terms of monitoring patients over time.
The idea about biochemical markers that tell us information other than just remodeling. So this morning I just focused on remodeling markers, but there are the ages that he talked about, which relate to the damage you can get from glycosylation of proteins. And there are assays for that. The best assays currently are using tandem mass spec, and they're not so widely available, but it's a very interesting area whether they could be valuable. And then there are also some isoforms of the CTX, which I didn't talk about, the alpha and the beta, which also tell us about the aging of the bone, which also can be informative. So these are all on the research agenda and are interesting and could be useful in the future.
Good. Barring any questions from public comment, I think that we are going to plow ahead. And let me thank our speakers for this session. We have Dr. Miller next, and followed by Dr. Hochberg, and then a break.
My name is Paul Miller, and I have been in this field a long time. Let me back up once. And I'm a very active practitioner. I'm a nephrologist, actually, by formal training, and then migrated into metabolic bone disease through the kidneys, and do a lot of work in that particular area. But I see about 80 patients a week. I'm a very active practitioner, a lot of complicated people. I'm with a group now of wonderful big orthopedic surgeons that are learning metabolic bone disease and how to incorporate all the things that we're teaching them here into this, and they give me a lot of support, and I wanted to thank them for my research and other support that they have. These are my disclosures. So the summary of the findings, when I was asked to present this more clinical approach, I think some of these are critical and just don't get addressed very well. Asking patients if they've ever had a low trauma fracture is an important component of the medical history that frequently we don't ask. Height measurements and doing spine x-rays or VFA on those patients with a loss of height more than 1.5 inches should become a standard of care and maybe should be a quality measure for payment. The diagnosis of osteoporosis based on fracture trumps T-scores. That's not a political comment. It's simply the fact that regardless of what the bone density is, the presence of a low trauma fractures makes the diagnosis regardless of the T-score. That statement cannot be overemphasized more because of the fact that we have a huge problem in clinical implementation of insurance companies denying payment because the patient doesn't have osteoporosis. The T-score certainly does not trump fractures. Fractures make the diagnosis, period. And there are many diseases that we treat that have impairment bone quality, which is the other half of bone strength that we can't measure in clinical practice, such as diabetes or people on steroids or people with more severe chronic kidney failure who fracture because they have a bone quality issue. And fractures demand a secondary workup and treatment. Not all kinds of fractures are postmenopausal or male osteoporosis. We have to think about other diseases that can cause fractures, such as osteogenesis imperfecta or osteomalacia, or some of the rare bone diseases that we follow very carefully as well, such as TIO or hypophosphatasia. This was the NIH definition of osteoporosis that was printed and published in 2000. And today, here in 2018, it still stands firm. A skeletal disorder characterized by compromised bone strength, predisposing to an increased risk for fracture. Bone strength is a composite of bone density, which we can measure, and bone quality, which we can't measure in clinical practice. Trabecular bone score gives us an indicator, but is certainly imperfect. So bridging the gap, research knowledge to practice, I've divided this into the left-hand side of what research shows, and to the right-hand side where the gaps are. One, research has shown definitely that specific low trauma fractures in patients 50 years of age and older is the single greatest risk factor for a second fracture. The gap, practice gap, most physicians don't even grasp this message. It's not impugning the busy physician that Dr. Gill sees with all the primary care problems that they do. It's simply that the message has not gotten through. They do not look for the asymptomatic vertebral compression fracture, and again, don't know that fractures are the key to making the diagnosis above and beyond whatever bone density number is there. 2, the research has shown that treat the 50 year of age or older with either gender fracture with pharmacological therapy, again, independent of the bone density number. And a lot of this is addressing the payer denials and problems. And of course, Dan Solomon's great data shows the falling rate of pharmacological treatment even for a hospitalized patient with a hip fracture. And hopefully FLS implementation might address this. This is one of many studies to show that a low trauma fracture, in this particular study by Colts-Butcher, wrist, vertebrae, and hip predict fractures at other skeletal sites, whether it be soft, whether it be our NORA data in terms of Colles fractures. The fracture is symbolic of systemic skeletal fragility, and that's how I convey that to patients. I only had a wrist fracture, doctor, but yes, you have a high risk for hip fractures as well. And that is a message that needs to be conveyed with greater articulation. Research and gaps, treatments. Research has unequivocal evidence that pharmacological therapy with FDA-approved agents reduces the risk of fracture in postmenopausal women, in men, and in glucocorticoid-induced osteoporosis. Fear, the bisphosphonate, this has been addressed many times. Atypical femur fracture, irresponsible media hype. It was March the 10th, 2010, has really killed bisphosphonates, with fear trickling over into all other therapies. The patients that I want to think about denosumab ask me if that's a similar compound and doesn't do the same things, and I'm afraid to take it. It's a challenge. I was in San Antonio, Texas at the ISCD annual meeting when this came on ABC Evening News that night on the Thursday. I got home and I had 88 phone calls waiting for me Monday morning about patients stopping their bisphosphonates. And in all due respect, our science and our professional societies have not been successful in mitigating this fear. And that's a challenge for all of us, no matter what organizations that we're devoted to, and most of us are devoted to all the ones, ASBMR and the NOF, the NBHA, the AC Room, ISCD, and go on, to work together to address this terrible issue. Research and gaps. Research has shown that even asymptomatic vertebral compression fracture is associated with a high risk for subsequent vertebral and non-vertebral fractures in untreated patients. Providers do not measure height accurately or look for vertebral compression fracture by X-ray or VFA, even if patients have lost 1.5 inches or more from what they thought they were. And I think the gap in it here is that most patients are measured by the MA, the medical assistant in the office. And they put down, and they may not know how to do it correctly. And they put down the number on a chart that gets back to the doctor without even being highlighted that this might be a particular of concern. I'd like to see the ability of the MA who measures the height to automatically be able to order the X-ray, so they can do it right there at the point of care if somebody has fulfilled that criteria. That would be a bigger, major step forward. Right now, it's not allowed in the healthcare system. This is a picture on the left of the late Betsy McClung doing her measurements accurately on a stadiometer on a patient who was totally asymptomatic but had lost 3 inches in height. And the X-ray to the right shows the vertebral compression fracture. Changes the diagnosis, changes the risk, changes the management if that is found. So I think Richard probably showed some of these from the UK. We worked very hard with multiple organizations to get Medicare to cover these for certain indications of when to do an X-ray or a VFA. And certainly somebody with a height loss ought to be number one. I mean, we miss that all the time. The steroid stuff Ken can talk about more later. But these are some of the indications that are reimbursed currently for when to do these measurements. This is from the NOF guidelines. Though often unrecognized, identification of vertebral fractures is important. A vertebral fracture, clinical or morphometric, is the indication for pharmacological treatment. Once the workup for secondary causes, including things that we see commonly, celiac disease and other kind of issues, are ruled out. The consequences of these fractures are enormous. We deal with these day in and day out. They have an increased risk for falls. They may have no pain, but they've lost balance. They're going to have more fractures if they're untreated. And there's a high mortality. This is a slide from the Dubos Australian population studies looking at survival by type of fractures in women on the left over a 10-year period, actually maybe up to 20-year period, under the age of 65, from 50 to 75, and men on the right. And the different colors, the different types of fractures, the blue being hip fractures, the green being vertebral fractures. And look at it, this is not picking out, but the men. The blue line shows their survival after a hip fracture. But look at the green line. In the earlier years, it's even faster and more mortality than hip fractures. And there are multiple reasons behind this. It may be the diseases that they accompany, but these fractures are significant and we miss them and we can't take them lightly. Low BMD is a strong predictor for future fracture, yet DEXA accessibility is declining. Despite the great recommendations of the United States Prevention Services Task Force and the U.S. Surgeon General's office that all postmenopausal women obtain a BMD at age 65 regardless of risk factors, the number of DEXA machines available in the United States has declined by nearly 50% in freestanding facilities. In Colorado, we've lost half. If you don't have the machine, you can't test. You can't make a diagnosis. You're not going to treat. Associated with the lower accessibility of DEXA machines, the number of people being screened for osteoporosis as a consequence. This is not case-finding strategies. This is a recommendation for population screening. The number of people being treated has steadily declined. And the major reason for the decline in most osteoporosis diagnosis is the cut in DEXA reimbursement in 2012 from $124 to $34 for Medicare. This has never been a cash cow. If we could just get it to break even, we'd see this field turn around to some degree and membership in many societies increasing. This is the slide that you've seen before from Mike Lewicki, and it just shows the trend. If you look at the light blue bars, Medicare reimbursement started to go down and then went down in 2012 to about $37, $38 for freestanding facilities. Hospital-based facilities, they kept the price the same. This was a broad radiological change for all radiological devices, where reimbursement for hospital-based facilities was maintained, for freestanding facilities was cut. To me, that's discrimination. But the point is that if you have a machine where the break-even, and we've calculated this, is about $90, and you're paying them $37, you can't keep it open. I'm blessed that I can keep my machines open because of my research grants, but I'm different, and I'm lucky, and I'm blessed for that. But this is what's happening, and what that trend have been diagnosis going down, number of people, DEXA testing going down, and of course the number of people being treated going down. Age and risk. This was the first study, 1988. Connie Johnston, University of Indiana, and the group, Missouri, showing the relationship between low bone density, age, and fracture risk, so that the fracture risk doubles by decade of age at the same bone density. This was a great landmark study, and it's been repeated many, many times by other work. There's a couple of points in here. First of all, if you take a look at the 50 to 59, it's pretty flat. It's a little increased. And our recommendations are guidelines, if you're postmenopausal where the average age is 51 and you have a T-score of -2.5 to treat. I think a healthy person doesn't want to get treated at 50. And those guidelines have to be changed. We're over-treating the low-risk people, and as you know, we're under-treating the high-risk people. So fracture risk doubles by decade from 50 forward, even at the same T-score. The reason for this well-documented relationship is due in part to increased fall risk and also deterioration in bone quality with age, which is half of the bone strength. There are no office-based bone quality measurement tools, and I would love to see all the great scientists that work in this area get together and develop some affordable office-based quality measurement. But the lack of the knowledge of the age-risk relationships leads to over-treatment of low-risk people and under-treatment of high-risk people. FRAX. We were on the FRAX committee. It's a great piece of work. But as we look back on it, try to use it, I think one of the greatest faults of FRAX, if I can use that, is that it never captured fall data. It's a health economic model, where if one were to reassess FRAX with a drug price of $14, you treat everyone. And if you try to do this health economic model of when it becomes cost effective to treat, based on the price of the drug at $3,200, you treat no one. The insurance companies, and I put here non-responsible, but I better use the word non-accountable. I'm in front of patients where I'm accountable. Here's my face, here's my card, call me. If you don't like me, you can have your lawyer call me. But I'm accountable. And then all of a sudden we get denied our treatment by somebody who's not accountable. And that has to be, there needs to be a change in that. An example of the importance of falls, because now I spend half of my time with patients working on teaching them fall methods. We have little balance things. I get on them and show them how to do things, because non-vertebral fractures occur after falls. If we reduce the risk of falls, we reduce the risk of non-vertebral fractures. So here's the FRAX data, where a patient who was 85, a T-score of -2.5, 4 vertebral fractures, 4 falls. That's the FRAX number, obviously without falls. The Garvin model, the Dubos model that captured falls, is a much smaller study, I understand. You can see the impact of the falls on the hip fractures and any osteoporotic fractures. Vertebral fractures occur while we're walking around Wisconsin Avenue, but non-vertebral fractures occur after falls. So research has shown that most non-vertebral fractures occur after falls, and most practitioners do not appreciate the fall issue. Research has shown that balance ability begins to decline from age 65 on. I can attribute to that. And that falls begin to increase also from age 65 on, and there's lots of data on this. Most providers do not test for balance in their office. It takes time. Or clinical sarcopenia, a grip strength. When I walk into the room, most patients stand up. I don't know if that's for respect or whether or not I'm just getting older. But they stand up, and I watch them how they stand up and see if they can get out of a chair without using their hands. Simple things, observations that begin to make me think to focus on certain areas. And we discuss all kind of fall prevention strategies and get people into PT, yoga, Tai Chi, Pilates, anything at all that will keep in their minds the fact that they've got to work on this particular issue. We don't spend enough time with this. Advise against the risky behavior of fall. This is a slide given me by Nelson Watts. We do this all the time. And we see patients do this all the time. And after you have fallen and you're broken, you go, boy, that was a stupid thing for me to do. But that's human behavior. The other thing about the steps that I wanted to point out is that we always point out to patients, what's the most dangerous step going down? It's the last step. They're looking ahead. It blends into the floor. We see more lower extremity fractures with the last step. I'm going to write a little paper called The Last Step. So we have a lot of work to do with patients that doesn't cost a lot of money and doesn't expose them to medications, which I use a lot of. But the fall risk is something that needs to have a major emphasis in this particular area. Key recommendations: educate, train, and retrain all providers that a single low trauma fracture in either gender, and you can include the other major fractures that were captured in FRAX, from age 50 on and older is the single most important risk factor for future fracture, independent of the prevailing BMD or T-score. Height measurements and acting on substantial height loss should become a performance measurement for payment. Mitigating fear of all of our FDA-approved treatments for osteoporosis is a constant physician-patient dialogue. We spend so much time at this. Increased DEXA reimbursement to at least a break-even amount would be a huge step in the field. And fall prevention strategies that are maintained throughout life should be discussed annually from age 65 on. And with that, I'll end and say thank you very, very much for your inviting me here today.
Good morning, everybody. So I'm Mark Hochberg. I'm trained as a general internist and rheumatologist and as an epidemiologist, but I'm mostly an administrator these days, although I do see patients 2 half-days a week and 1 month a year on general medicine. I want to thank Drs. Chen and Joseph for the invitation to speak this morning, and I've been asked to discuss clinical practice guidelines. And these were introduced yesterday morning by Dr. Gill, who talked about the U.S. Preventive Services Task Force recommendations for screening and the ACP recommendations for treatment. These are my disclosures. My consulting is solely in the area of osteoarthritis, not in the area of osteoporosis. Osteoarthritis is my major research focus these days. And I'm also here because I'm president of the United States Bone and Joint Initiative, which is the U.S. National Action Network in the WHO-sponsored Global Musculoskeletal Disease Initiative, which grew out of the Bone and Joint Decade. So this is my summary. So there's broad agreement for measuring bone mineral density to diagnose osteoporosis in postmenopausal women. You've heard this before. It's a right in the United States, RIGHT, that all women age 65 and above should have a DEXA paid for by Medicare. It doesn't happen. And there's clearly a lack of consensus for BMD testing in men, who've been discussed a little bit during this conference. Now, if you look at the guidelines, clinical practice guidelines, there's relative agreement on many aspects of the management of osteoporosis in postmenopausal women. And for those areas where the guidelines differ, the practitioner is urged to follow her best clinical judgment. And I follow the principle of shared decision-making. This has not been elucidated really during the course of this meeting yet, but it encompasses sitting down, presenting the evidence to the patient, having a discussion, which often primary care providers do not have the time to do during a 20-minute visit. But Dr. Adler noted that at the VA you have time to do this, and you generally have time to do this in an academic practice. So let's talk about diagnosis. You've heard this already before. I'll go over this very briefly. This is really the composite National Bone Health Alliance from the NOF, National Osteoporosis Foundation, American Society for Bone and Mineral Research. A T-score of less than -2.5, someone who's experienced a hip fracture or having low bone mineral density with a history of a vertebral fracture, a humeral fracture, a pelvic fracture, or a distal forearm or wrist fracture. And then having an elevated fracture risk based on FRAX. So this is where you would consider a diagnosis to lead to treatment. Now, what about the management in 2018 as we go to guidelines? So there's no cure for osteoporosis. We can approach this as a treat-to-target strategy, which as a rheumatologist we're used to doing in patients with rheumatoid arthritis, hyperuricemia secondary to gout, joint pain secondary to osteoarthritis. And our goals are listed here. Now, there was discussion yesterday about what the primary care provider should do, and several of the patients said, Well, their primary care providers didn't know what to do when they were faced with a diagnosis of osteoporosis. Well, what to do is refer to an osteoporosis specialist to evaluate for secondary causes of osteoporosis and conditions which complicate management. And who are these osteoporosis specialists? They're largely endocrinologists, rheumatologists, some geriatricians, and some primary care providers who've taken advanced education. And then for fracture management, incorporate a fracture liaison service if available in your community hospital or academic hospital in patients who experience a fragility fracture. And I think that Dr. Tosi is here in the audience representing the American Orthopedic Association, who might speak to this during the question and answer period later on. So we've talked about treatment gaps. Many people are not tested to diagnose osteoporosis, and many people with osteoporotic fractures are not diagnosed with osteoporosis by their healthcare providers, and consequently not receiving FDA-effective pharmacologic therapies. And you've seen the data from Dr. Solomon's studies using the Medicare, and I can tell you personally that in the Baltimore hip studies, where we follow patients who are admitted to community hospitals, they're community-dwelling adults, they have a fresh hip fracture, they get surgically repaired, there's been no improvement in the 20% of people who get started on therapy in the year after fractures in the past 20 years that I've been working with Dr. Jay Magaziner in these projects. Now, you've seen these slides already as well from Mike Lewicki's paper in OI earlier this year, showing you the annual incidence of hip fracture on the left, where there's a flattening out as opposed to the anticipated decline. And this has an ecologic association with a reduction in osteoporosis diagnosis, a reduction in DEXA testing, a reduction in the number of office DEXA providers, but a maintenance or slight increase in the radiology providers in hospitals. And Dr. Miller has already addressed this. And now DEXAs are being done in the hospital, not in the office, and radiologists are not really trained. I hate to say this to my radiology colleagues, but you get a report that says osteoporosis, osteopenia, there's no FRAC score included, and there's little real guidance in terms of how you interpret the DEXA. And there are mistakes in the readings. So how have I gone about preparing this presentation? I searched the U.S. National Library of Medicine using PubMed from January of 2000 to September 30th, because I updated the presentation. I used the search terms listed here. I identified 79 articles, of which 68 were English language. I don't read non-English language articles. I chose the most recent when there were multiple papers from the same society, such as the ACP or the U.S. Preventive Services Task Force. And I included only those from U.S.-based societies, because we're currently in the United States. This is an NIH-funded conference that applied to either postmenopausal women in general or older men. I did not focus on individual high-risk disease groups like celiac disease, chronic kidney disease, chronic liver disease, glucocorticoid-induced patients. So I ended up reviewing these 5 recommendations. I cite the names of the organizations and the date of publication. One of these is now no longer routinely available. It's the Department of Veterans Affairs Information Letter on Osteoporosis in Men, published in 2017, which underwent sunsetting, but I'll show you the algorithm from that. And Dr. Adler was the chair of the committee that put this together. So I'm going to start with the NOF recommendations. And I'm told that these are currently under revision and that we should see an update in 2019. So there are 3 slides for NOF recommendations. The first are the universal. These are the lifestyle recommendations. And we heard yesterday from the women that they followed these lifestyle recommendations, but it didn't prevent their getting a fracture. So maybe they're helpful in terms of maintaining bone strength and bone quality during adulthood and during the early postmenopausal period. We advise on diet. We advise on vitamin D intake. There's controversy about whether we should measure 25-hydroxy-D levels in patients who are at risk for deficiency or in the overall geriatric population. We recommend weight-bearing and muscle-strengthening exercise, and I, too, refer patients for Tai Chi and yoga and balance training, and I do single chair stands routinely in my clinical practice. I assess risk factors for falls, and we obviously advise on cessation of smoking and avoidance of excess alcohol intake. We recommend diagnostic assessment. So we've talked about measuring BMD using DEXA in all women age 65 and above. But we really haven't talked about men very much. And the recommendations that we'll talk about that the NOF suggests are men age 70 and above should have a routine DEXA measurement. And then there are the younger postmenopausal women and the men over age 50 who've had an osteoporotic-related fracture at an adult age. And Dr. Miller discussed this. I had a radial fracture at the age of 55, and I underwent a DEXA test, ordered by one of my colleagues. And then we should perform vertebral fracture assessment. And you've heard about this from Dr. Estelle and from Dr. Miller in people with low bone mineral density, and women aged 70 and above and men aged 80 and above, or in younger people who have even lower bone mineral density, even if they don't have osteoporosis, because it influences treatment decisions. We don't do tests unless they influence treatment decisions. I learned that as a fellow 40 years ago. So what about the U.S. Preventive Services Task Force? The old recommendations from 2011 are on the left. The new recommendations from 2018 are on the right. The big change is the younger postmenopausal women who are at increased risk for fracture as determined by a formal clinical risk assessment tool. Dr. Gill reviewed for you yesterday 5 such tools that are available. He recommended the OST because it's the simplest, weight in kilograms minus age times 0.2. And you can also calculate the FRAX measure using using weight instead of bone mineral density. The U.S. Preventive Services Task Force says there's insufficient evidence to support screening for osteoporosis in men. Insufficient evidence for the task force gives a capital I. Insufficient evidence in clinical practice doesn't mean you shouldn't do it. It means you should rely on consensus recommendations of experts. So what about pharmacologic treatment? Recommendations for initiating pharmacologic treatment are shown here from the NOF. You've heard about these before, and I'm not going to repeat them. So where do the other recommendations differ? So the AACE Clinical Practice Guidelines for Postmenopausal Osteoporosis are similar to the NOF recommendations, except for these 4 bullet points. Using the NBHA definition for the diagnosis of osteoporosis, recommending specific anti-resorptive agents as initial therapy for most patients who are candidates for treatment, recommending more potent agents, including teriparatide, for patients who are unable to use oral therapy or at especially high risk, following up on what Dr. Kosman spoke about yesterday, and recommending against vertebroplasty and kyphoplasty as first-line treatments for vertebral fractures, which have been shown not to be more efficacious than sham procedures for pain relief. What about the ACP recommendations published last year? Well, there are strong recommendations for offering pharmacologic therapy with anti-resorptive therapy and against using menopausal estrogen therapy or raloxifene. Dr. Jackson spoke to this yesterday. And there are weak recommendations using the grade system for treating osteoporotic women for 5 years. This can be a topic of discussion. There's a weak recommendation against monitoring bone density during the 5-year treatment period. There's a weak recommendation for offering pharmacologic therapy with bisphosphonates. I would say there should be a strong recommendation and a weak recommendation for using principles of shared decision-making. I think this should be a strong recommendation, personally. Now, there are several areas that were identified as inconclusive. Comparative effectiveness trials are lacking. This was discussed yesterday. And the optimal treatment duration is unknown. And we've talked about this here at the conference with regard to, quote, holidays, unquote, with bisphosphonate therapy, and balancing the benefits of future fracture risk reduction versus the harms, and you've heard about all this. Now, concerns have been raised among osteoporosis specialists about the ACP guidelines, and these are summarized in a paper by Ligari and colleagues in Clinical Therapeutics earlier this year. They did not recommend anabolic therapy as frontline agents in patients with severe osteoporosis. Dr. Kosman spoke to this yesterday. The treatment duration is arbitrary at 5 years, and it should not apply to denosumab. There's no indication for a drug holiday after denosumab. Monitoring of BMD may affect adherence to therapy, as discussed by Dr. Silverman yesterday, and a decline in BMD greater than the least significant difference may indicate a lack of responsiveness or efficacy. And raloxifene may be an appropriate treatment for younger postmenopausal women at high risk for vertebral fractures, especially if they're at high risk for breast cancer. This is one of the drugs which has been shown to be effective at chemoprevention for breast cancer. Now, what about osteoporosis in men? Finish up with the VA information letter. There's a gender disparity that's recognized in mortality and disability rates in hip fracture. Men have a greater mortality following hip fracture than women do within the first year and are more likely to have disability. So the VA information letter provided an algorithm for case finding in men aged 50 and above, how to pursue a clinical evaluation of men with low BMD, and lifestyle counseling and pharmacological treatment. And this is probably not in your evidence report, but it's in the slide, and you can see it here. I won't go into it in detail because I'm already running over. The Endocrine Society has also spoken about recommendations for osteoporosis in men, supports the NOF in measuring BMD in men aged 70 and above, and those aged 50 and above with risk factors. Their universal recommendations are similar to NOF, and they recommend pharmacological treatment for men aged 50 and above with the subsequent indications. So the key recommendations at the close are to increase awareness that low trauma fractures in older adults are due to osteoporosis. And fall prevention strategies, as already mentioned, are part of the multidisciplinary intervention for secondary fracture prevention. And I would suggest that everybody go to the ASBMR-sponsored website, which I didn't list the URL here, but I'm sure that Dr. Keel and Dr. Khosla will provide it. I think it's www.secondaryfractures.org, to look at the recommendations for secondary fracture prevention. And that all the groups now should come together, similar to what the USBJI sponsored with the Chronic Osteoarthritis Management Initiative, to have a chronic osteoporosis management initiative and develop consensus recommendations for BMD testing and management, including the relevant patient and professional societies, so that we can educate patients and providers that the benefits of treatment vastly outweigh the potential harms of adverse events. I want to thank you very much for your time and attention, and I want to apologize to Dr. Joseph that I didn't include the National Institute on Aging logo on the bottom of this slide. Thank you.
Good morning. I'm Ken Sag. I'm a rheumatologist and outcomes researcher at the University of Alabama at Birmingham, and I also want to thank the organizers for the invitation to be part of this great meeting. And I'm going to give the first of two presentations focused on implementation science. I'll talk predominantly about patient and provider approaches, and then Dan Solomon and I have coordinated our talks a bit. He's going to focus more on system approaches and some of the financial implications. So here are my relevant disclosures, which include some sources of funding, including some of the grants that have supported some of the work I'll describe, and my relationships in the past and still with NOF and the ACR, as well as private sector entities. So here is a summary that pertains both to the comments I'm going to make and also to some of the things that I think Dan will cover. First, that we have an increasing armamentarium of evidence implementation interventions. Some of these have been shown to be slightly successful. Many of these have been shown to be modestly successful in selected groups, and a great many of the things that we've looked at have actually not worked at all. System approaches, practice redesign, has largely been superior to approaches that target patients or providers. And I think as relevant, partly the reason we're all here at this meeting is that implementing evidence at the community level is not easy. We've seen the great evidence that we have in osteoporosis, but how do we translate that research effectively into practice? Technology offers us promises, context and engagement are key. The idea of a teachable moment, this may come right after a fracture, can be very impactful in leading to a change. We've thought that multimodal approaches are better, and in some cases this is true, but in general, one size fits none. And for those of us in this area, we feel very strongly that we ought to be testing these approaches in a controlled setting to really figure out what works and what doesn't work. So what is implementation research? It's at the intersection between research and quality improvement. It uses methods from health services research and qualitative methods. It's translational science that goes beyond the bedside. If we look at the spectrum from the Institute of Medicine of clinical research, we can see early phase translational research, and we can see T3 and T4 research, and that's where this area of science really fits in. So it's the study of methods to promote rapid uptake of research findings and to reduce inappropriate care and improve the health of individuals and populations. And it differs from traditional quality improvement because we're trying to generate knowledge. We're trying to figure out what works and what doesn't work. Quality improvement works, there's no doubt about that. It works locally, but often we don't really know what it is we did and what actually worked in a PDSA type of approach. So what are some of the things historically that have been used and what's worked and what hasn't worked in general? Well, we can give out guidelines and other printed materials. That doesn't work. You can go to a traditional CME lecture, or you can give one, and people get smarter, but they don't change the way they practice. We can do intensive conferencing around things like smoking cessation, very effective, but utilizes a lot of resources. You can use computerized tools. This has great promise, although many clinicians have figured out how to turn off all these pop-ups in the EHR. And then the idea of outreach visits in a specialized form, academic detailing, has been shown to work very well, but costs a lot of money. I'll talk a little bit about audit feedback and also allude further to multifaceted approaches. Now, it's really important as we look at the literature to keep in mind the tremendous heterogeneity in the studies that we're going to review. There's a lot of variability in the quality of the studies. Some are true RCTs, often accounting for clustering. Others are open label, observational, uncontrolled. There's lots of different targets. I'll talk about that, as will Dan. Primary versus secondary prevention and the timing of the fracture event ends up being quite important in influencing some of the results. And are we talking about trying to get people on therapy and to test initially, or as we heard yesterday from Debbie Gold, when we start to think about adherence, this is more complicated as well. And then there's different types of osteoporosis. I've had an interest in steroid-induced bone disease, and the factors there may be different than, say, postmenopausal bone disease. And very importantly, what works in Europe, what works in a managed care system, a group model HMO in the US, may not work in our disorganized fee-for-service environment. So here's an example of one of the problems, this pervasive care gap between what doctors know and what they do. And you can see that about 90% of the time, doctors are wrong about what they're doing in terms of quality improvement. And it's like asking doctors how they take care of patients and what they do is similar to asking patients about how much they smoke. And as we heard yesterday, I think Dr. Gill gave a great talk and really highlighted that while at the patient level and at the system level, there may be problems with information, at the physician level, it's really more about lack of time, inertia, poorly aligned incentives. These are really the major barriers, not so much lack of knowledge. So here's an example from Diabetes of Audit Feedback. This was done by my colleagues at UAB using something known as the Achievable Benchmark of Care. It's a standard that was established based on the top 10% of physicians with the Bayesian adjustment for the size of your practice. And you can see across a number of quality metrics in diabetes that providing this feedback along with the statewide project average shows how that person is doing. Physicians and healthcare providers tend to be very competitive, so you see this report and it may influence how you practice. And indeed, the ABCs led to a significantly greater rate of uptake of these quality measures than did traditional feedback, and CMS adopted this as a standard approach. Well, we thought we would apply this to a population of patients within a managed care organization who were using glucocorticoids. We figured out who their doctors were. We randomized the doctors on the internet to get or not get an intervention, assessed at baseline their rates of testing and treatment, and did the same after the intervention. The intervention used adult learning theory. It was tailored. It had this achievable benchmark of care. You could get online continuing medical education credit. And we rolled it out over a 6-month period to try to combat decay. And here's what we found. In the intent to treat analysis, we did not see a benefit of this strategy, either in terms of testing or treatment. When we looked at a subset of doctors who did what we asked, who went online, who downloaded their feedback, who did the cases, we start to see some trends, perhaps towards some benefit. And it really speaks to this issue of engagement. And other studies in steroid-induced osteoporosis have reached similar conclusions. It's a very difficult, non-teachable moment, if you will. You can see the RCTs and some non-randomized trials also with negative results. There was one study that actually looked a little bit more promising, and that was kind of an unusual, slightly odd intervention in Tasmania. The study was non-randomized, pre-post. The intervention was in northern Tasmania, the control in southern Tasmania. They measured the outcome among hospitalized patients who are not exactly where we would expect to see osteoporosis care being delivered. But you see some small improvement, a slightly unusual approach. It's really important, again, to look under the hood and see what these studies are doing. In contrast, this is, I think, a really very elegantly done, somewhat simple approach to the problem. And I want to honor the late Sumit Majumdar, who really did some very thoughtful work in this field. And he showed that if you just take x-rays, chest x-rays that are done in the ED, and you message the physicians in real time, in the pink bars, you can see that this resulted in significant increases in treatment testing or either compared with usual care. The addition of a patient educational approach was modestly additionally beneficial, but it suggests that some strategies, particularly when there's a teachable moment, may be effective. So it's really caused us to reconsider the targets of these approaches and to think about moving away from the physician and provider. They're just too busy. How do we better engage the healthcare system, and can we go and activate patients to get them more engaged in improving their care? So here's a patient activation intervention funded by NIA, done by Peter Cram as the PI at Iowa with UAB and Kaiser of Georgia collaborating. 2 arms, usual care or a tailored letter containing DEXA test information and an educational brochure aimed at trying to better educate patients about their results and do this in a standardized way to promote a more meaningful engagement with the physician. You can see the study required a fairly large sample size, which we achieved. And you can see a lot of the women, mostly Caucasian, completed the study. And in the primary analysis, there was not a difference in terms of the intervention versus the control for guideline concordant therapy. Now, we did see some movement along the continuum. We saw that patients were more likely to know their DEXA results, and they were significantly more likely to speak with their physicians. And these are necessary preliminary steps to improving quality with a target at the patient level. Another approach is to think about the idea of narrative communication, storytelling, testimonials, and you turn on the TV and you see an ad and you can relate to that ad. It has to do with homophily, being able to relate to the people that are telling the stories. The power of narrative to change belief has never been doubted and has always been feared. So brainwashing, if you will, but hopefully for a positive outcome. And here was a study in hypertension done by Jerome Allison and Tom Houston at UAB. A very nice, simple study as well, using a very grainy home movie style DVD, sitting patients down in the waiting room at the Safety Net Hospital and showing them pictures of older men similar to them, similar race, ethnicity, talking about what happens when you don't take your blood pressure medicine. And you can see the impact this had in improving blood pressure control, better than what we might see in some clinical trials, and particularly good among the men that had particularly bad blood pressure initially. So we did this within the GLOW cohort. This has been described by other speakers. We conducted an RCT looking at usual care. We delivered our materials either online or for people that didn't have computer access as a mailed-out DVD. The sample size accounted for the clustering, the interclass correlation, a design effect should be used to address this analytically. And you can see how difficult it is to get to the patients. Having email, having cell phone access resulted in still a relatively modest 45% engagement with the website. And you can look at all the different things we had to do to try to achieve this. And this just shows you the level of tailoring that we use based either on known barriers to therapy or on the Prochaska levels of readiness for change. And we gave little video snippets that were race, age, and sex appropriate in an effort to try to tailor this to either barriers or concerns that these individuals might have. I wanted to just show you one of these snippets, and the way we developed the stories is we did qualitative work with patients, and then we did some editing and took those stories and had them portrayed by actresses or actors who were of the same race, ethnicity, and age range of the patients who we were targeting.
And when I look at the odds as far as how often ONJ may happen compared to my family history of osteoporosis, down to even my father and my grandfather having osteoporosis, I would say that I would have a better chance of a better outcome taking the medicine versus doing nothing.
Well, again, it's difficult to improve quality. No differences in treatment rates between the intervention and control arms. There were more individuals in the intervention arm that shifted from a pre-contemplative to a contemplative state. And this is an interesting finding. Be careful what you wish for, because when we gave information to these patients about their barriers, they actually became more concerned about some of these things. It really depends who's delivering some of the messages. Some of the subgroup analyses look promising, and you can see that a lot of studies have been done. This is just a sample of some of the ones that has been done. Dan did one of the largest looking at a motivational interviewing approach. You can see that it was bordering on statistical significance, but MPRs, medication possession ratios, were relatively low. The one study in this list that looks successful was actually after people already had a prescription, and they were given an opportunity to get some interactive voice response calls in an effort to get them to actually start their medicine, and that actually worked. So there's many steps in this idea of activating patients. We have to make sure the patient is aware. We got to get the patient and physician to discuss this. The physician needs to take action in either ordering a test or prescribing a therapy. The patient then needs to fill their prescription, and take the medicine, leading to this change in process of care, which based on the RCTs that we've been hearing about, ought to lead to a benefit and an outcome, namely reduction in fractures. So it's a multi-stage, complex pathway, involves patients and clinicians, and success, as we saw in the last example, may depend on where you are in this pathway. Being farther along may make it easier to get to a beneficial place. So let me spend just a minute and then turn this over to Dan on system interventions and show you one example of a system approach within two of the Kaiser systems that we worked with, Kaiser in Georgia and Kaiser Northwest. And this was a multimodal intervention that involved a very simple, low-tech system redesign approach of allowing women to schedule their own DEXA. You can get your own flu shot, you can get your own mammogram. Why not give them a 1-800 number and let them schedule their own DEXA? We also provided some patient education, and based on our experience with provider interventions, that actually served as a control group to bring the physicians on board and agree to participate and let their patients participate within the Kaiser. And what we saw is that the system approach, the practice redesign of allowing people to schedule their own DEXAs within both Kaisers resulted in a significant increase in appropriate DEXA utilization. We didn't see an added value of the patient intervention, and you can see how usual care remained relatively low. So there's been a host of approaches at a system level. Dan's going to talk more extensively about this. Here's a couple of examples with pharmacy-delivered interventions and other forms of different forms of fracture liaison services. The one study here that doesn't look like it worked all that well had a ceiling effect. The medication possession ratio is already up around 80%, so you wouldn't expect necessarily to do a whole lot better than that. And I want to just conclude really with this slide, because I think while I've switched over to system interventions, and this involved both sort of practice redesign as well as provider approaches, it emphasizes that this idea of a teachable moment in getting people right after a fracture and thinking about secondary fracture prevention looks to be the area where we have the greatest likelihood of having an impact, about a 20% improvement overall across these 9 RCTs, which were examined in a meta-analytic approach. And lastly, just to highlight this work from Sachs and Chalmers, some of the pioneers in evidence-based medicine, that we need to be very careful about studies that aren't controlled. And you may see things that look just tremendous, but when you actually study them, as several of the examples illustrated today, sometimes things don't work the way we think. So I want to conclude with a few recommendations. Randomized controlled implementation trials aimed at improving osteoporosis process of care are needed. System and multimodal approaches are recommended over patient and provider alone targets. Well-defined interventions may include active comparators. This may be necessary in the real world in order to get health systems, patients, and providers engaged. And we need to rigorously define what works, when it works, in whom it works, and we need to do this at a population level. I didn't have time to talk about quasi-experimental designs, interrupted time series, step wedges. These are approaches that may be useful when we really don't have equipoise to do randomization. And it may be very cost-effective at a federal level to think about leveraging large observational studies like GLOW, although maybe in a different way in the future, that may provide efficiencies of scale. So I want to acknowledge some of my collaborators, and thank you for your time and attention.
Thanks, Ken. That was a great warm-up to my act. And I want to thank the organizers, and I want to thank everybody for hanging in there. It's day 2 of a long conference with a lot of detailed talks. And I would say that the implementation science is really the critical piece in trying to improve care. We have a lot of evidence about the benefits and a lot of evidence about the science, but we don't have a lot of success stories about how to improve care. And implementation science is probably one of the softer sciences, but it is a science that we can learn a lot from, and I think we need to build on what we understand already. So my disclosures, I have a number of research grants. These are really involved with rheumatoid arthritis and not specifically osteoporosis. So to summarize before I start, primary prevention of osteoporosis is hindered by confusion regarding treatment safety and lack of widespread use of screening tools by most clinicians. Secondary prevention is limited by a fragmented post-fracture care system, and I'll describe that in a little more detail. All the rigorously conducted primary prevention studies in the U.S. have been negative. Ken put a positive spin on some studies that I think, if we look carefully, we describe them as negative studies. But some of the other studies from other locations have been positive. System-level changes for secondary prevention using things like a fracture liaison service and FLS do seem to be effective and seem to provide good value, and I'll talk a little bit more about the economics. And while implementation science provides a roadmap for interventions, there are a few rigorous interventions that have been conducted that change the financing of care. And I would posit that the financing of care is likely the most potent lever for some of these system changes. So again, the problem is, we've been hearing about it for the last day and a half. It's weak bones, it's falls, it's a lot of nuanced issues, but at the end of the day, it's a fracture. And the fracture in the healthcare system is often picked up by an ambulance, brought to the emergency department as a patient with an acute injury. And another way this hits the healthcare system is through radiology, when there's an incidental finding or perhaps not an incidental finding of someone who has a spine fracture. Clearly, orthopedic surgeons are often on the front line of dealing with these fractures when they can be repaired. And the issue becomes is that at the other end, where the prescriptions need to be made by primary care physicians, family physicians, rheumatologists, endocrinologists. You notice I put rheumatologists before endocrinologists, but that's kind of the friendly internal competition that we have here. But the problem is that too often this information really gets siloed and doesn't get from radiology to the prescriber. It doesn't get from the patient. It doesn't get from the emergency department, and it doesn't get from the orthopedic surgeon. And so often as a clinician, I'll hear about a patient who, after they had a fracture, the fracture was repaired, they spent a week in rehab, they come back to see me for some other rheumatic disease issue, and when I question them about what's happened to you in the last couple of months, I hear about these acute issues, and then we have to start figuring them out. So why don't most doctors recognize patients at risk for osteoporosis and provide the management? Clearly, there's two major clinical scenarios. There's lots of nuanced scenarios, but the two major: primary prevention, patient with no prior fracture, hasn't been diagnosed with osteoporosis. And clearly, we've heard all about the scarcity and confusion around BMD testing. The FRAX tool is used rarely in typical practice. There's other tools, but those are used, unfortunately, as well, infrequently. And there's uncertainty regarding treatments, risk versus benefits. I practice at Brigham and Women's Hospital, a lot of smart primary care doctors. Too often I'm calling the primary care physician, asking them, why exactly haven't you been prescribing something for this patient? There's something I'm not understanding. And then they get into a concern about bisphosphonates. And as we've heard, yes, there are some side effects, but these are incredibly rare. These are incredibly well tolerated medicines. And if they don't want a bisphosphonate, there are other medicines. So there's a lot of uncertainty. But there's the major and the low-hanging fruit, I think, in many of our minds is the secondary prevention, the prior fracture patient. And these are patients that end up with orthopedic surgeons who are often reluctant to treat it, the osteoporosis. Osteoporosis prescribers are often not alerted to the fracture occurrence, as I've described. And there's some uncertainty regarding treatment, as we've been discussing over the last day and a half. So we could think about the three levels for strategies of overcoming these barriers. And I think Ken alluded to this, that there's the individual clinician and or patient level. What are the strategies that focus on doctors and patients? And we can discuss those. Ken has already discussed some of them. There's the healthcare system. And we can think about the fracture liaison service as a system approach. So what should the FLS consist of, and how to actually deploy it effectively in a typical healthcare system. Healthcare systems are incredibly complex and diverse. And then there's the healthcare financing or insurance strategies. And who can affect such change, and what might it look like? And I've been to CMS, and I've talked to the bean counters, and I've been remarkably unsuccessful at trying to explain that we can actually improve care, lower costs, by making some structural changes to our financing system. So again, implementation science is what we're talking about. And the cartoon, if you can't read it, I'm not procrastinating. I'm proactively delaying the implementation of the energy-intensive phase of the project until the enthusiasm factor is at its maximum effectiveness. And as anybody who's worked in complex systems, healthcare or otherwise, it is so easy to not try to implement complex changes, because these system changes they're difficult. You have to get many people on the team to all speak the same language and realize they have the same goal. And these are people that already have very busy lives. And so implementing change really takes a tremendous amount of energy and work, and too often it doesn't occur. But we know that there's this huge delay from the basic research all the way through the publication, the synthesis, evidence-based guidelines that we've discussed here today, and then maybe years later we see a change in practice. And this is the kind of the 17-year odyssey that people have described. And oftentimes Ken showed you one diagram of implementation science. Here's another from the basic research, tremendously important. We have to then think about translating the basic science to human science. We think about the clinical science under ideal conditions, and then we think about how to diffuse it into non-ideal settings, non-ideal conditions. And sometimes we see that there's diffusion, perhaps of higher-end evidence. As Howard's described, some of the evidence synthesis is tremendously important, but sometimes the level of evidence is weak or insufficient. And other times there's no diffusion at all, and we have to kind of work on figuring out how to get the science into the hands of clinicians to improve the population health. So again, thinking about these three levels of targets, we can think at the individual clinician and patient level, which Ken has described, the healthcare system level, and the healthcare financing. And I just want to talk through some of the pros and cons. At the individual clinician and patient level, Ken's already shown you some rather unsuccessful studies, some of them that I've mainly driven. Doctors, on the pro side, doctors have responsibility for appropriate care. They typically need to order the testing and the medications when appropriate. Patients want to be engaged and take responsibility, and I think Ken's recent study really pushed on that issue and unfortunately did not change behavior. Affecting positive improvement, one clinician at a time, is unbelievably labor-intensive and time-intensive. And many of the solutions may not be transferable across settings. There's so much diversity. As Ken said, one size fits none. You have to tailor these interventions in such a nuanced way that it's really quite difficult. At the healthcare system level, these are systems issues. System problems require system solutions. Intervening on the system is much more efficient than intervening one clinician and patient at a time. And again, if we think about a fracture liaison service, if we create that service in a trust, in the UK or across a large healthcare system, Kaiser, Partners, UAB, et cetera, perhaps we can really affect change at a broad level. However, the cons, the healthcare systems differ so tremendously, so the solutions may not be easily transferable. And we all know that changing healthcare systems is incredibly hard. It's really a team sport. As Jim Gill described, you have to get everybody focused, and again, everybody is so involved in their own silo, their own activities, that getting everybody on the same page takes a lot of work. Healthcare financing changes, money speaks. Clinicians and healthcare systems figure out how to improve themselves when there's dollars on the line. If you say you're not going to get paid for taking care of a hip fracture unless the patient gets screened and treated appropriately, things will change overnight. Changing healthcare financing sometimes takes an act of God, or at least of Congress. And I'm not quite sure how to affect that change myself. So what works to improve treatment rates? And I say this in North America because I've focused on US and Canada because I think these, the Tasmanian example that Ken gave, I'm not quite sure how applicable it would be in our setting here. Ken's already talked about Peter Cram's study, and this is Ken's study, Danila, the first author. The first study by Cram was individual level randomization at DEXA centers, I think about 7,500 patients. Guideline concordant osteoporosis care at 52 weeks was really no different in this individual level randomized trial. The Danila study that Ken was the PI on, these were women in GLOW, I think about 2,500 women, tailored education, direct-to-patient videos. Again, the osteoporosis treatment at 24 weeks really did not differ. Ken, I think, showed some of the intermediate endpoints where there may have been some difference. When we think about, and here what I'm showing you on the top here is the MD patient interventions, primary prevention, the Cram, secondary, the Danila. If we think about system-level changes like a fracture liaison service or FLS, there are no primary prevention because fracture liaison service is people who have fractured. So we think about secondary prevention, and this is the Jaglal study from Canada, published in 2012. I think it was about 35 community hospitals, cluster randomized trials, women over the age of 40, not under 40, sorry about that typo. It was a centralized coordinator with patient and PCP follow-up by telephone and mail. So it really looked like a fracture liaison service or an early version of that. It was a cluster randomized trial taking into account design effect. And they did see a significant improvement in guideline concordant osteoporosis care at 24 weeks, 32% in the intervention arm and 20% in usual care. So there are some positive evidence in controlled trials around FLS. And if we think about financing, there's nothing. And this is not to say that there aren't changes in financing that have occurred. There's plenty of, I was talking to Dr. Comston about the changes in the UK, and plenty of the trusts have changed, put more money on the line for fracture liaison services. There really aren't controlled trials of this that I'm aware of. I looked pretty hard and couldn't find them in North America or the US. Again, we haven't tried that here. There have been some other attempts, and there's several that are underway, but I couldn't find any of the published evidence to present here. So there is this one trial that I think is a very important one that just came out in the Lancet. Ken pointed it out to me, the SCOOP trial, Screening in the Community to Reduce Fractures in Older Women. It was a pragmatic, unblinded, two-arm randomized trial in 100 GP practices in the UK. It involved about 12,000 women, 6,000 in each arm. The women were aged 70 to 85, not 84, and they were not on osteoporosis drugs already. 3/4 had no fracture, so a quarter had a prior fracture. After giving informed consent, they all underwent this FRAX, which is a way of screening patients and assigning a risk of future fractures. And this was done prior to any BMD testing. After the FRAX was completed, they were randomized. And then they were assigned, based on their age, into these risk thresholds based on the table on the bottom left. So women who were 70 to 74, if their FRAX put them in below 5.2% for their future risk of fracture, they did not undergo BMD testing. If it was above 5.2%, they then underwent BMD testing. And then the high-risk women, as I show, undergo testing. Based on the testing, a letter was sent to the GP and to the patient. And so it was an educational intervention primarily based on this risk assessments to try to find the right patients And then there was a very simple education, again, a letter to the GP or the patient about their future risk of fracture and the need for treatment if they were at high risk. And if we look here, this is the intermediate endpoint, the percent of patients with prescription anti-osteoporosis medications. So in the cream-colored bar is the intervention or the screening arm, and at 1 year follow-up, it was at 15% of the women ended up on osteoporosis treatment in the screening or intervention treatment arm, 4% in control. So a very significant difference. Over the 5 years of follow-up, the 15% stayed pretty stable in the intervention arm, and the control arm went from 4% up to 10%. The primary outcome was any osteoporosis-related fracture, and over the 5 years of the trial, about 800 fractures in each arm, and there was no difference. So a simple educational, a targeted simple educational intervention with a letter to GPs and patients produced no change in the primary outcome. However, the secondary outcome, which was hip fractures, about 180 versus 210, 180 in the intervention arm, 210 in the control. And so there was a suggestion in the secondary outcome that this simple screening-based educational intervention was effective. So this is an interesting study. It was unblinded, obviously took place in the UK. There were some interesting differences that the authors noted between the patients who agreed to be randomized and those that didn't. The ones that agreed to be randomized had a higher SES, so there was a suggestion that certain patients would be more interested in this. Again, it was a very simple educational program. I wanted to turn my attention in the last couple of minutes talking about economics of fracture liaison services. This is a cost-effectiveness analysis that we published in 2014 in JBMR with several of my colleagues more expert at cost-effectiveness. We looked at whether fracture liaison service would be cost-effective, and we compared no fracture liaison service to universal fracture liaison service to a more targeted FLS based on DEXA. We examined the sensitivity of the findings to what was the target population, did they have a prior hip fracture, or other fractures, how we costed out the FLS, the efficacy in increasing bisphosphonate use of an FLS, and then the cost of medications. And I think many in the audience are familiar with this methodology. We adapted an existing computer simulation that John Skuzbo was able to help us with. We projected costs of the FLS program, of the DEXAs, of the medications, and then of the fracture-related costs, acute care costs, long-term care costs. And then we looked at the health benefits, which is measured as the quality-adjusted life years, looking at changes in life expectancy times utilities. We followed kind of standard methodology. We used a Markov state transition model, and this outlines it. Health states were well-defined, and then we look at clinical events after each cycle. There was a 1-year Markov cycle, and we used a number of estimates from the literature that were well-researched, and I'm not going to go through each of them, but these costs and fracture probabilities have been well estimated in the literature. Many of these studies outside of the US. And so our results, in the base case, we actually found that an FLS was cost-saving. It lowers costs, it improves quality-adjusted life years, so it's cost savings. It was very beneficial. It had very beneficial incremental cost-effectiveness ratios, ICERs, across all of our sensitivity analyses. We kind of went through many worst-case scenarios, and we were able to get it to cost $112,000, which is considered cost-effective in 2018. So we also examined how the cost of zoledronic acid would affect this, and we found that in multiple different costs of zoledronic acid, the FLS was still cost-effective. There's been other cost-effectiveness analyses that have shown about the same cost savings or very favorable ICERs from US and Canadian-based studies. So key recommendations: we have to focus on implementation science if we're really going to move the bar on osteoporosis care, more interventions at the healthcare system and healthcare financing level, Motivating clinicians with incentives for finding and managing undiagnosed osteoporosis and fractures is key. I would say that bundling insurance payments for fracture care with an FLS is also would change care and the patterns of care very quickly. We need to test the implementation of successful local interventions across health systems, and we need to include clinical outcomes in the trials because sometimes clinical outcomes don't follow some of our intermediate endpoints. So I will stop there, and I will put this quote from Walter Cronkite: "America's healthcare system is neither healthy, caring, nor a system."
Good morning. I'm Doug Bauer. I'm a general internist at UCSF, where I see patients and teach every week, and I really appreciate the opportunity to come talk and thank the organizers. I also wanted to thank the panel for taking time out of your busy lives to help us with these difficult issues. My talk, and I think Jane's the next one, is going to be a little bit more forward-facing and talk a little bit about the future, because I'm here to talk a little bit about a really exciting opportunity to use a very, very large database to answer some important questions related to some of the issues that we've been talking about. And I've entitled my talk, Predicting Fractures with Surrogate Markers. I have no disclosures. Okay, summary of the finding. I'd just like you to focus in on the third and the fourth bullet. Short-term treatment-related changes in bone mineral density are strongly related to the clinical outcomes that we are all interested in, which is hip, vertebral, and non-spine fractures. And most importantly, change in bone mineral density potentially meets several surrogacy outcome or criteria that we are pursuing with the FDA in the hopes of an FDA validation. Okay. The problem, and I won't spend much time here because I think we've heard about so many different aspects of this issue that we're here discussing today. But I think one issue that perhaps has not been appropriately highlighted is the pipeline for new treatments that are both more effective and potentially have fewer side effects. And of course, we all know that in this day and age, it's extremely difficult for new medications to make it through the pipeline and to be registered. This is at least in part because of very, very large sample sizes that are required for fracture endpoint trials, the prolonged endpoint, prolonged follow-up, not to mention the issues about equipoise and randomizing individuals to placebo in this day and age. Of course, this has led to a limited pipeline. Unfortunately, this appears to be validated. I quickly reviewed clinicaltrials.gov earlier this month, and there were no new drug listings for phase 3 or phase 4 fracture endpoint trials. So I think the pipeline is really surprisingly limited at this point for new medications that might be more efficacious or have fewer side effects. So this brings us to the issue about surrogacy, and surrogate endpoints, which we think might be a way forward to help speed up development of new medications. This is not new. There are accepted or validated surrogate endpoints for a variety of clinical diseases and outcomes, including HIV. So viral load is an accepted surrogate. Blood pressure is an accepted surrogate for stroke outcomes. And of course, lipids, specifically LDL, is an accepted surrogate for CHD outcomes. And of course, the point here is that validated surrogate endpoints for fracture could greatly reduce the needs for large trials, reduce the duration of these studies, as well as reduce the costs. And the FDA does have an opinion about this, and they have a number of requirements that they expect for the process of surrogate validation. And two of those requirements are shown here. The first is the compilation of study-level meta-regressions of multiple trials relating the potential surrogate with the clinical outcome of interest. And the second is individual-level analyses estimating the percent of treatment effect, or PTE, explained by the surrogate on the outcome of interest. And I'm going to spend a bit of time talking about those two FDA requirements. By the way, there are certainly other FDA requirements related to the context of use, et cetera, but these are the two really high bar requirements for surrogacy validation. So, in terms of our field, preventing fractures, there are really two, I think, at least on the current horizon, potential surrogate outcomes which may be of interest and are particular interest to our group. The first is skeletal imaging, and again, you've heard a lot during the last 2 days about the use of imaging, in particular DEXA. As previously pointed out, there are small but quite precise changes with treatment in these imaging modalities over time. And what's quite interesting about this is that the hope, but it's certainly not proven, is that the treatment-related changes in these imaging modalities might not be, may be independent of what the mechanism is. For example, a increase or beneficial effect on the imaging may be similar for both a anabolic or for a anti-resorptive agent. There have been several which have been proposed. Finite element analysis has gotten a lot of interest. Of course, this is a computer-intensive analysis of imaging, highly correlated with strength. The problem is it's rarely obtained in routine fracture trials, and therefore it hasn't been possible to do the types of analyses that I'm going to show you for FEA. Bone mineral density, routinely obtained, used both in trials as well as in clinical practice. We also know that it's moderately correlated with skeletal strength in vitro, and as I mentioned, it's routinely obtained in trials. Dr. Estelle has really done a beautiful job of explaining biochemical markers, which I'll shorten to BTMs. The advantages here are they're very large and rapid treatment-related changes. The problem is that they are very drug mechanism specific, and of the bone turnover markers change, or the effects are quite different for anti-resorptive and anabolic agents. Okay. So now this gives me an opportunity to tell you and give you an update about the Foundation for NIH Bone Quality Study, which has been done by myself and the Dennis Black, who's the PI, as well as a number of people in the audience, including Richard Estelle. It's funded by the Foundation for NIH. And the goal of this study is to study potential surrogates for fracture, including DEXA-BMD, QCT, FEA, and bone turnover. The study began over 5 years ago when we requested raw data, that is individual level data from all placebo-controlled osteoporosis trials with fracture endpoints. There were a few exclusions, mostly excluding small or short-term studies, and we specifically did not seek to obtain data for trials that were performed in disease populations, for example, in those with secondary causes of osteoporosis, such as breast cancer or corticosteroid-induced osteoporosis. Happy to report to date, we've been quite successful in obtaining a really substantial amount of data. Again, this is individual level data. It's all been received at UCSF, cleaned, and we have now begun to analyze it. To date, we have data from about 40 trials, that includes over 150,000 randomized participants. This is just a summary of the trials that we've received to date, and some of you, if you can read in the back, will notice that this includes a wide variety of anti-resorptive agents, including the oral bisphosphonates, intravenous bisphosphonates, a substantial number of individuals. We also have other anti-resorptive trials, including denosumab, and as well as SERM data, as well as anabolic therapies. Again, it's important to note that most of these studies were conducted by industry, and they've been extremely helpful to have their collaborative participation to obtain this individual level data. Okay. And I'd like to return to the types of analyses that are going to be requested by the FDA to validate an individual, validate a surrogate marker for fracture. And we'll really be focusing in on bone mineral density primarily. Again, I mentioned finite element analysis, which requires CT scans, and there just is too few of those measurements made in randomized controlled trials to do the types of analyses I'm going to talk about. But as mentioned, the first request by the FDA is to do a meta-regression of study-level data among published trials. And this has now been done using this data set with several different analyses, presentations, and manuscripts. And this is just a representative example looking at change in bone mineral density, relating that to the average reduction in fracture. Each one of these little bubbles, as you know, is a randomized controlled trial. They are plotted on the difference between the treatment and the placebo groups
on the x-axis and the relative hazard for non-vertebral fracture reduction on this axis, and then a line is plotted. As you can see, there's this includes both anti-resorptive as well as anabolic agents with a reasonably high correlation, highly statistically significant. The conclusion here is that there's a strong and significant association between bone mineral density change and fracture risk reduction in this meta-regression of published of study-level data. Interestingly, we did similar analyses using bone turnover markers. Again, this was one of the figures was shown by Dr. Estelle in his paper. The results are very, very similar. That is, greater reductions in bone turnover at the study level are associated with greater reductions in fracture using this a technique of meta-regression. The second request by the FDA is to present PTE analysis, that is the proportion of drug treatment effect explained by the potential surrogate. As opposed to the meta-regressions, which are study-level analyses, this requires individual-level data. So data from each randomized participant from placebo-controlled trials. And the overall approach to PTE, for those of you not familiar with it, we use the Friedman method, which is to estimate the PTE from both the observed treatment effect both before and after adjustment for the surrogate of interest. And I'll just give you 3 examples here of a hypothetical osteoporosis treatment that reduces fractures by 50%, so the relative risk is 0.5. In example number 1, after adjusting for the surrogate of interest, the relative risk stays at 0.5, meaning that the PTE is 0. In other words, the surrogate did not account for any of the observed effect, any of the observed beneficial effect of the treatment. In example number 2, same relative risk to begin with. After adjusting for the surrogate of interest, the relative risk goes to 1. PTE is now 100%, meaning that the surrogate accounts for 100% of the observed effect of the intervention. And number 3 would be a more typical real-world example where the PTE is 26% after adjustment for PTE. So PTEs have been reported for a number of individual randomized controlled trials. This has been done for both bone mineral density as well as BTMs related to a variety of different fracture outcomes. And in general, these have been quite variable. This is understandable because both the methods to calculate the PTE as well as the specific approach has differed. And the confidence intervals have been quite wide. And importantly, there's been no PTEs reported for hip fracture. So a hypothesis from our study was that we could improve this analysis of PTEs by using the pooled data from FINH, using multiple trials as well as consistent methods across all of the studies. So this is some of the methods to actually calculate BMD PTE. We examined the relationship between change in bone mineral density measured at 3 sites, the total hip, femoral neck, and lumbar spine, as well as looking at 3 fracture outcomes that you've heard about over the last 2 days, vertebral fractures, hip fractures, and non-vertebral fractures. And for the bone mineral density PTE analysis, we pooled 22 randomized controlled trials, which included not only anti-resorptives, 4 BP trials, 4 SERMs, denosumab, and HRT, but also anabolics, 3 studies, as well as odonacatamab. So you can see this is a substantial undertaking in terms of collating this amount of raw data from this number of individuals. As you can see that for each of the fracture outcomes, there were a substantial number of events, over 4,000 for vertebral and almost 900 for hip fracture. Oh, I did want to point out that these analyses have not yet been published, but were presented by Dennis Black at ASBMR just a month or so ago. Okay, these are all overall results then for PTEs relating the 24-month change in bone mineral density at 3 sites to the 3 fracture outcomes. Each of the fracture outcomes is a row. The bone mineral density sites are columns. And as you can see, for vertebral fractures, the PTEs ranged from a low of 30% at the spine to a high of around 60% at the hip. Notice that the confidence intervals exclude 0, and therefore these are all statistically significant. It's important to point out that the lower bound of the confidence interval is important because this gives us an estimate of the minimal amount of PTE, that is the least plausible amount that the surrogate accounts for. So you'd interpret this as saying for total hip bone mineral density and vertebral fracture outcomes, total hip accounts for at least 50% of the effect of these drugs. For hip fractures, the results were similar, PTEs ranging from 40% to 50%, and for non-spine fracture, somewhat surprisingly, the PTEs tended to be even higher with a low of 50 to a high of 70%. So we did similar analyses for the bone turnover markers, as I mentioned. These were also presented at ASBMR earlier this year, and I'll just summarize to say that the results were qualitatively similar, but the confidence intervals were quite a bit wider for the 3 BTMs that we analyzed, bone alkaline phosphatase, P1NP, and CTX, suggesting that it's perhaps a less useful parameter for this type of analysis, PTE. Also want to point out that these results are consistent between the different types of analyses, which I think should be reassuring to the FDA. We did a simple estimate saying that an osteoporosis treatment that increased spine bone mineral density by 3% would be expected to reduce vertebral fracture by about 63% in the analyses of study level meta-regression, and would be expected to reduce vertebral fractures by about 56% in the individual level meta-analyses that I've just shown. Similarly, for the BTMs, an anti-resorptive therapy that reduced P1NP by 30% would be expected to reduce vertebral fracture by about 42% in the published meta-regression and 31% in the individual level PTE analyses. So quite a bit of consistency between those two approaches. So just to conclude, after pooling multiple osteoporosis treatment trials, short-term changes in both bone mineral density and bone turnover markers are associated with fracture risk reduction in meta-regressions. These associations were strong and statistically significant. And importantly, both changes in BMD and BTMs account for a substantial proportion of the observed treatment effect as calculated by PTE. And it's interesting to note that hip bone mineral density had a higher PTE than spine bone mineral density, even for spine fractures. And another important conclusion of these analyses is that BTMs, although certainly were qualitatively in the same direction, had considerably more imprecision of the estimates and may not be as useful for this type of analysis. And we feel that these results may fulfill some of the requirements for FDA qualification. Just a couple of implications and next steps before I turn the mic over to Jane to summarize the 2 days. If validated, the use of these potential surrogates might reduce the need for large fracture trials. But it's important to point out that these surrogacy analyses would not address safety concerns. Again, these are efficacy surrogates, and the issues related to safety concerns would still need to be addressed by other study designs and other potential surrogates. We are currently pursuing FDA qualification for a change in bone mineral density as a surrogate for fracture outcomes. And I'm happy to report, since Dennis presented this data at ASBMR in Montreal, we've received an encouraging letter of response from the FDA stating that they support this endeavor and encourage us to continue. So at least from the FDA standpoint, they're encouraging us to move forward. And we are hopeful because these results, we believe, compare favorably to the other surrogates which have been previously validated. Recommendations. One thing through this process has been quite unclear exactly what the FDA is thinking, so our one recommendation is just to work with the FDA to clarify clearly what their preferences are for both the study design as well as the rigor of both the context of use as well as the specific analyses for the studies, and to help explore what are the specific criteria that would be must be reached for validation. And finally, to promote further types of additional work in this area would be to promote the measurement of potential surrogate outcomes by embedding them in future trials and facilitating trials across trials, as well as encouraging industry to share data for pooling efforts such as was done here. I just want to acknowledge that this has been a huge team effort. Gail Lester, who's in the audience, is the chair of our FINH project. Dennis Black, who you heard from, is the PI. But this is really a host of individuals that have helped, as well as companies, funders, as well as hard work by our colleagues at UCSF. And I really appreciate your time, and thank you very much.
Hello, it's a pleasure to be here. Thank you very much for Drs. Chen and Joseph for inviting me to speak. And thank you also for all of you for sitting down and listening to all these talks, and I'm the last talk, so thank you for your patience. So I felt a need, because of the horrific things that happened in Pittsburgh, that I wanted to acknowledge that Pittsburgh is very much a football town. We have a baseball team, but we're not really, as really, the Pirates haven't been very good for a long time. But one time, GQ magazine called the men in Pittsburgh the worst dressed men in the United States. And they said this was because it's game day every day. So you wear your Steelers shirts all the time. So I just wanted to show that the Steeler community and the Pittsburgh community is very much behind our Jewish community and our friends. And we're all supportive of trying to be stronger than the hate that has happened in our country as of late. Okay. So thank you. So I have nothing to disclose. So the summary of our findings, Dr. Chen and Joseph asked me to summarize all the talks that have been going on for the last day and a half. And I had to base that on the early sets of slides that were distributed. And so some of it I may have not got exactly right because you've changed your slides over that course. But basically, we know from Dr. Shane that osteoporosis is a significant public health problem, and there's also a crisis in the treatment of osteoporosis. Short-term treatment decreases fracture risk by about 20 to 60%. Long-term treatment decreased vertebral fractures but had no effect on non-vertebral fractures from the 2 extension studies. Initiation of drug therapy and adherence to drug therapy is poor. The risks, especially with long-term use of AFF and ONJ, have been summarized. There's little data on long-term treatment and drug holiday. And in the future, we have ongoing initiatives, which I'm going to describe, by ASBMR, IOF, and the Fracture Fragility Network. Implementation science, AFF and ONJ, perhaps the development of a risk factor algorithm would be better to target our therapies to patients who are not at high risk for AFF. Development, Doug just went over beautifully, the development of BMD as a surrogate marker, need more data on long-term treatments, and as well as drug holidays. So in terms of the scope of the problem, it's a health threat for 44 Americans. About 10 million in the US have osteoporosis, and another 34 million have low bone mass. 68% of those that are affected are women. 1 out of every 2 women and 1 out of every 5 men will experience an osteoporotic fracture in their lifetime. Fractures are associated with significant morbidity, disability, and mortality. Fractures beget more fractures, and the current cost is over $17 billion annually in the US. And the osteoporosis treatment after hip fracture is bad news about that, and it's getting worse. So the key question 1 was, what are the benefits and risks, including major adverse events of osteoporotic fractures over the short term, less than 3 years of treatment, and what factors influence the outcome? And we learned about this from Drs. Khosla and Rosen. We know that there are highly efficacious treatments, 20 to 60% decreases in fracture risk, but there's not a cure. It's not 100% discount, not 100% decreased risk. We want to treat women at the higher risk, which is those women who have a previous fracture, low BMD, they're age 65 and older with risk factors. But there are research gaps. Whether, when, and for whom do we continue treatment after 3 years? And we need to engage our primary care physicians, and we need to listen to our patients better. And of course, we need new drugs, especially antibiotics, because we need a cure. Right now, they don't, as I mentioned, they don't decrease fractures 100%. And this is a slide from Dr. Rosen, who recommended that who we treatment. I pretty much went over this, and he summarized who we don't want to necessarily treat at the time. Okay, the P2P, key question 2. What are the benefits and risk of osteoporosis drugs over the longer term, greater than 3 years, and what factors influence those outcomes? And we don't have a lot of data here. Most of the data comes from the FLEX trial, which was an extension of the FIT trial of alendronate, and the extension of the Horizon trial, which is an extension of the zoledronic acid trial. And many of our speakers spoke to this. And we have evidence that continuing drug therapy for 3 to 5 years may reduce vertebral fractures, but had no effect on non-spine fracture risk, although Dr. Black showed that there was when compared to the virtual control group, there would be some effect on non-vertebral fractures. The risk of AFF increases with duration of use. Perhaps the development of a FRAX-like score for AFF, better understanding of the pathogenesis of AFF, the genetics of AFF, and perhaps using rare bone disease models and efforts to minimize the risk. The ONJ increased with bisphosphonate use. The meta-analysis said there was about a 2 to 3 times increased risk. And Dr. Juliette Compston went over the risk of atrial fibrillation and mortality and GI cancers, and we really need more data there. Hormone therapy by Dr. Jackson was not recommended for the primary management of osteoporosis, but perhaps there's some area of using low-dose estrogen and transdermal estrogen that may be promising in women who are having hot flashes who also have osteoporosis. We need, from Dr. Cosman, we learned that proactive anabolic therapy use and sequential monotherapy for our highest risk patient may in fact minimize duration of use and maximize benefit. And finally, more evidence is needed on the long-term treatment regarding the risk benefits and who, when, and how we should target our long-term therapy. This was also shown by Dr. Rosen that secondary fracture prevention works. This was the Ken Lyle study showing that giving Zol after a hip fracture reduces clinical fractures as well as mortality. So the P2P question 3 was, do drug holidays improve outcomes? And this was reviewed by Dr. Schoback and Estelle, although many of the other speakers did speak to drug holidays. So BMD at the hip, a T-score less than -2.5 at the end of first line of treatment may be a marker for women who should remain on therapy. Older age and higher risk of falling, perhaps Dr. Schoback suggested that there's caution regarding a drug holiday in these patients. There's no guidelines, there's evidence lacking, and future research should use BMD and bone turnover marker during a drug holiday and changes in BMD and fracture risk to help perhaps target who should be on a drug therapy. And the bone turnover marker data was also elegantly described by Dr. Estelle, as well as the BMD data, and noted that perhaps a vertebral fracture assessment may also be utilized for deciding who, in fact, would benefit from continued long-term use. So the P2 question 4, both parts 1 and 2, was drug therapy for osteoporosis prevention, patient and clinician factors affecting initiation and adherence. This was covered by a number of speakers. And we know that initiation and adherence to our drugs are poor. There are barriers to treatment in primary care that were reviewed. The best model to implement screening and treatment in primary care is really not known. The options in dosing intervals didn't seem to have any effect, as Dr. Gold reviewed. And both the patients, the doctors, and the system contribute to these barriers, these lack of initiation and the poor adherence. The challenges are both media coverage of our medicines and demographic factors. We need to improve communication, and we need to consider the patient perspective and perhaps consider the risk of no treatments on their personal life, their roles as a wife, as a mother, as a daughter, etc. And improve the perception of the risk and benefits. The drugs work very well. These risks are real, but they are rare, thankfully. But we need to improve the perception of these risks and benefits. In the future, Dr. Solomon and Sag talked about inflammation science, 3 levels of target. And we target individual clinicians and patients, the healthcare system, as well as healthcare financing, and perhaps incorporating fracture liaison services would be one way to improve our treatment, improve the treatment gap. And we need to define what is high quality care, and we need RCTs that actually improve osteoporosis process of care. Dr. Sag showed you that without a control group, it looks like we are seeing a benefit, but the controlled studies did not have the same effect. So we really need our randomized trials funded to try interventions to improve the process of care. So the future, Dr. Bauer talked about the FNIH Bone Quality Project, about BMD as a surrogate marker, short-term changes in BMD and bone turnover marker are associated with fracture risk reduction, and at least BMD does, account for a substantial proportion of the observed treatment effect. And now this application from the FDA is moving on. I just wanted to also present ASBMR's initiative that's focused on secondary fracture prevention. And this was led by Dr. Keel and Dr. Khosla, who are both in the audience. So this is, just wanted to call, this was a paper that was a task force about, from ASBMR that was published in 2012, making the first fracture the last fracture, and it was a report on secondary fracture prevention. So ASBMR has been really concerned about secondary fracture prevention for quite a long time. In 2016, there was an ASB call to action. You can see the press conference that was held by many of the speakers that are here today. And there are 39 U.S. and global organizations that have pledged to intensify efforts to increase screening, diagnosis, and treatment of high-risk individuals. And then in 2017, we developed a strategic roadmap and action plan to prevent the secondary fractures. This is a neutral platform for many multi-stakeholders, dialogue and action, and we have a 40-organization coalition. The target plan, and this is really important, so the ASBMR secondary fracture prevention is focusing on men and women aged 65 years and over who have suffered a hip or vertebral fracture that comes to clinical attention. And we are saying these individuals should be evaluated for treatment. This subpopulation we know is at very high risk for a second fracture, and evidence is robust in supporting treatment of this population. It's not intended to imply that other populations should not be treated. I mean, all the patients need to be evaluated as individual, but we want to target this population because it's well-defined, and we think that there's general consensus on that a public health initiative is indeed achievable. And these are some of the steps that we have carried out in developing the action plan and the clinical recommendations. There is a steering committee and a coalition. I mentioned of about 40 organizations. They went through steps to identify lessons learned from other programs, such as cholesterol reduction. What did we learn about that? Develop information for educational and supportive materials, and we want to really identify a quantitative goal, like how much of the how can we improve a goal of reducing secondary fractures. They have initiated, as Dr. Solomon mentioned, money talks. So we have initiated a discussion with a CMS to improve reimbursement options, for example, for fracture liaison service. And we think that part of the confusion of the amongst primary care, perhaps, is all the different recommendations. These were summarized by Dr. Hochberg, and he noted how they differ and where they're similar. But perhaps we can develop consensus recommendations, and that will help primary care clinicians in terms of secondary fracture prevention. We're disseminating the action plan. I believe it's on the ASBMR website. And we are coordinating our messages and exploring pilot studies with integrated health systems. So this is the bottom line. I mentioned that who should be treated, and we think that the multidisciplinary clinical system that includes case management, such as an FLS, and the bottom line is that these people aged 65 years and over who experience a hip or vertebral fracture should be treated for osteoporosis. And this, again, just lists some of the elements of our action plan, promote clinical recommendations. We wanted to establish a national fracture registry, but that seems to be running into some difficulties given the many different health systems that we have in the United States. It's not as easy as in a country like the UK or some of our Scandinavian colleagues. We want to increase the number of capabilities of case management and fracture liaison services, improve the diagnosis and communication about patients with vertebral fractures, and explore potential uses of reimbursement and financial incentives. And again, these are some of our other action plan elements, which you can read about on the website. And Mark Hochberg did, in fact, get the website correct. And it's shown here on the slide, www.secondaryfractures.org, to get more information about the ASBMR's Secondary Fracture Prevention Initiative. So what else is happening around the world? I got these next couple slides from Dr. Cyrus Cooper, who is the president of IOF, and they're really focusing on their program called Capture the Fracture. And it's a global campaign facilitating the implementation of coordinator-based post-fracture models of care for secondary fracture prevention. And so they award these various levels of achievement to various programs. And the growth of the FLS network has been remarkable, from a number of 57 in 2013 up to 246. And you can see from this slide that it's really all over the world, and 40 countries, and over 300,000 fragility fractures have been seen by the FLS network. And there's also the Fragility Fracture Network has a program, and you can see that their global call to action was published in the manuscript, the journal Injury, just in August of 2018. These next slides come from Paul Mitchell, and they're also focusing on multidisciplinary care for any person who suffers a hip, clinical vert, or other major fragility fractures. They're focusing, again, also on rapid secondary prevention after the first occurrence of these fractures, and it's ongoing post-acute care of people who has the ability to function is impaired by hip and major fragility fractures. So really focusing on the disability that's associated with these fractures. And so just to summarize, each one of the talks had a key recommendation. So I'm just briefly summarizing it, but I think the panel would be really important for you to look at the key recommendations of each of the speakers. So we need to generate more evidence for long-term treatment for decision-making. This is a major research gap and opportunity. In fact, we need to know when, who, how, perhaps what drug, what sequential therapies of drug should be used for a drug holiday. I think it's really important for the three major organizations that are focused on secondary fracture prevention that they collaborate. And I know at our last ASBMR meeting, we had a session and we had representatives from all three organizations talk about their individual programs. I think the idea of moving forward with implementation science is very exciting, and I think that Dr. Solomon and Dr. Sag brought up some important ways that perhaps we can improve care by focusing on the system. Focusing on the healthcare system and financing, including case management models such as fracture liaison services. We need to increase awareness by the patient, families, and providers, including primary care, and really increase the understanding of the media of our problem and about the importance of the drugs and the safety of the drugs and the rarity of these side effects. Simplify clinical guidelines along the ASBMR, follow the ASBMR effort. And of course, to prevent fractures, we need to, Dr. Miller talked about fall prevention strategies and making sure that these are incorporated into our primary care. Thank you very much. It's been a pleasure.
So first of all, let me thank Dr. Cawley for giving us a first working draft, at least, of the report. Let me turn to the panelists for the first round of questions.
Thank you, everyone. Are we missing a panelist? So thank you for all your presentations and your work. I think one of the things we learned was the many disciplines that may be related to the secondary prevention or even the primary screening of those at risk for osteoporosis and potential treatments. I was wondering, we heard on a couple different speakers mention sarcopenia. Often, many of the NIH-supported presentations I've attended focus a lot on sarcopenia. I can't help but think bones and muscles must have some tangential relationship, as well as a lot of work on falling really works on balance and strength exercises. So could you maybe talk about it in a context also of sarcopenia?
Okay, I'll start. So when I'm in clinic, I routinely do a single chair stand on patients. And I tell the postdoctoral fellows, internal medicine residents, medical students, that the inability to perform a single chair stand predicts falls, predicts hip fracture, predicts going into a nursing home, and predicts mortality within the first year. And this is largely due to lower extremity proximal muscle weakness. Now, sarcopenia is a construct, and it's a construct which includes either muscle weakness, which is easily measured by grip strength, for which there are standardized population normative data, as well as low appendicular muscle mass, measured by full body DEXA, and slow walking speed, variably defined, but most commonly is less than 0.8 meters per second. It's difficult in routine clinical practice, even in a clinical research setting, to measure walking speed. We've laid out in our VA in the hallway a 3-meter path with blue tape on the floor, but it's tough to include measuring regular and fast walking speed during routine clinical visits. The VA has 20 funded geriatric research, education, and clinical centers. The majority of these are involved in rehabilitation research. Ours certainly is in Baltimore, and we have experts in measuring sarcopenia, Dr. Alice Ryan, who uses full body DEXA to look at appendicular lean mass. Dr. Brock Beamer, whose special area of interest is in falls and balance research, exercise facilities, etc. So sarcopenia contributes because it's a risk factor for fall, and fall is the risk factor for non-vertebral fractures. Two of the women yesterday mentioned falling while they were walking their dogs. I mentioned this to Ann Elderkin this morning. So maybe that's something that needs to be considered. There are beneficial effects of having pets, but maybe there are harmful effects of having pets. So yes, so there's a muscle-bone interaction. Dr. Keel, I think, chaired a symposium at ASBMR about this in the past. There's going to be one next year on muscle-bone interaction the day before the annual meeting, and this is clearly of research interest.
I just wanted to say, I would point out there is Peggy Cawthon at Doug Shop, UCSF, and Shally Bassine at Harvard have a research grant, because one of the difficulties with sarcopenia has been the definition of sarcopenia. And so I think that's hindered some of the research in that area. So they have a consensus panel to develop and recommend definitions of sarcopenia. So I think that will be coming out. I know we have a meeting right before the gerontology meeting in November.
And I would just add, there's also a large PCORI-funded study looking at ways to reduce falls. I think it's a critical question. It really is perhaps the one thing we didn't emphasize enough in this series of talks at this meeting, because as you've heard, hip fractures are the major cause of morbidity and mortality in osteoporosis, and if you don't fall, you don't generally break your hip. So we've got to figure out a way to understand the basic biology of falls. Sarcopenia contributes along with medications, perhaps dogs, neurologic issues, arthritis. Many things contribute, and we've got to address that. And then we've got to think about what are the interventions that we can define that have good veracity and good generalizability that will reduce the risk of falling.
Along those lines, often our oldest have the greatest risk of falls. And I was wondering if some of these system-level interventions, how those would actually apply to our Americans in skilled nursing facilities, in assisted living situations, in those who may be less savvy with technology. And yet, when we talk about who is at the highest risk, I haven't heard anybody talk about Alzheimer's or related dementias, and possibly the difficulties in the treatment of this growing population.
Well, I'll just add that, again, I think you've highlighted a key research agenda area. I know that several of us work with an investigator in the U.S. who just received funding for a large study in Parkinson's disease that I believe NIA is going to support. And that's going to really be critical in addressing some of the issues you're raising that go beyond traditional osteoporosis risk groups, but deal with people, in this case, with serious neurologic illness that are at a high risk for falls.
Yeah, I think I would comment, we've reported from the Women's Health and Aging study that older women with Parkinson's disease were at increased risk of hip fracture. And it's well recognized that various conditions that are associated with an increased risk of falls are risk factors for hip fracture. And I think in these populations that you describe, more attention needs to be directed towards the provision of rehabilitation services and assistive devices, particularly quad canes, walkers, and other assistive devices, in order to try and reduce the risk of falls in this population, as well as getting rid of throw rugs, trying to get people to live on one level, etc., slippers and various and sundry shoes as well.
I just wanted to point out Dr. Susan Greenspan, who happens to be at the University of Pittsburgh, she did a study of Zoll in a nursing home, and it wasn't powered to look at fractures, but she did show that the drug was well tolerated in these very old patients, and it did improve bone density. So that's the one study that I can think of that was done in a nursing home.
I have a question.
I just wanted to add one quick thing about, actually there's a follow-up study for that study, which is actually a fracture endpoint. It's called ZES2. The Parkinson's study, which was alluded to, is a really novel study because it's going to be all done in home, both the evaluation and the administration of yearly Zoll. And we estimate 20 to 30% of those participants will have cognitive dysfunction.
A question on the FRAX methodology. Two messages came out this morning. One, that it doesn't reconcile the fall issue, and then the other message, like, is the only thing out there. So what's the sense in terms of FRAX?
On this?
Well, when FRAX came out, I think we were all very excited because it had validated 9 risk factors and how they interacted to predict risk. And those are valuable because the risk factors themselves, and they're printed out on the DEXA machines, and that helps the physician because the people who don't recognize or haven't recognized other risk factors now think about those risk factors, and that's very valuable. I think one of the problems is the fact that for me, in my particular practice situation where I see a lot of people who have already had a fracture, as soon as they've had a fracture, I don't need to calculate a FRAX score. I need to be worked up and treated. And so it has limitations in there as well as the fall issue. I think that I can gather a lot of information by talking to patients and looking at their bone density, looking at their fracture, looking at their lateral films to see they have a vertebral fracture, and I don't get a lot of additional information from it.
Let me just add, I think FRAX has been a major advance in the field. It moved us from the idea of relative risk, which is what a T-score is, to an idea of absolute risk, which is not how do you compare with the person sitting next to you, but what's your risk over the next 10 years of breaking something. So that's been the big public health advance. Yes, it's imperfect, and it's imperfect in large part because of the databases that are used to create it. And including something like falls in there would be wonderful, but it's not systematically captured in large international databases. So it becomes challenging to pull in all of the factors that form the large regression equation that led to its creation. So it's the best we have, and there's other screening tools that are out there, but I think FRAX has been a major advance in our field.
And I just wanted to speak to FRAX. I think before FRAX, it was just based on, maybe treatment decisions were based on bone mineral density, but it moves clinicians to consider not only bone density, but clinical risk factors, because most of the large cohort studies have shown that even if you have, a good BMD, but you've got 6 risk factors, you have a high risk of fracture. So I think it's combining them, and that's why it's important.
Did we lose Dr. Solomon, by the way? We did? Okay. Dr. Lohman, Dr. Charles? No? Okay. Ken, perhaps this falls to you. I mean, we have a rich evidence base here in osteoporosis treatment, drug treatment, but we also have some gaps, as Dr. Cawley, summarized, in her comments. And Dan Solomon told us, that implementation science ought to be the focus, and I was just wondering, to what extent do you believe that some of these gaps, particularly in terms of who we treat, when we start, with what, in what sequence, et cetera, pose barriers and issues for an implementation science approach?
Well, no, I think your question raises an important point, and that is I don't think we can overstep the evidence. And we've got really great evidence around the efficacy of a number of very effective therapies across a number of risk groups, where many groups, including ASBMR, NOF, several that Jane summarized so nicely, have focused is on what many of us consider to be the low-hanging fruit, and that's people after a fracture. If you fall down from standing height and you break your hip, there's not a lot of debate that you need to be evaluated and very much likely treated for osteoporosis. That constitutes a fragility fracture, and there I think there's not much debate about moving from efficacy to effectiveness to scaling this up at a national, international level. Other circumstances we may be earlier. We may need more efficacy data. We may need to figure out how to better balance risks and benefits around other selected groups. But for people that are post-fractures, for those on high-dose glucocorticoids, I mean, these are groups that we've got the data. And so now we just have to figure out how to translate it into practice.
Questions from the audience?
My name is Laura Ryan. I'm from Columbus, Ohio. I wanted to add about FRAX. In my own practice, I find it's a very useful implementation tool. It's a visual aid to help patients get a better sense of their risk of fracture. But my question for the panel was, there's been a lot of talk about drug holiday, and there's not really been any mention of what to do after denosumab, after 6 years, after 8 years. The fracture data that we have only goes to 10 years, kind of. I was just curious if you are aware of any studies that will be helping to answer what to do with denosumab.
The long-term safety data is very reassuring, and I think safety in practice trumps efficacy. But I mean, the long-term safety data is very reassuring that we just published in OI not too long ago. I think Mike McClung was the first author. The drug is metabolized. It's metabolized in the reticuloendothelial system. It has no negative effect on GFR or kidney function. That's why it's safe, and we got to watch the serum calcium in that population. In people who have had prior fractures, it's risky business to stop. And my concept to patients that you and I are going to be committed to this for a long time. Now, I don't plan to retire. I love what I do. I'll work when I can't work anymore. And I tell them, if for some reason we lose contact, by whatever reason, or you move, you make sure you communicate with us so we can find you a provider to stay on it. Because to stop it, particularly if you've had fractures, is associated with a rebound increase in fractures. So I'm looking at this right now as long-term, maybe lifelong therapy. I don't have the safety data 20 years out, and but hopefully we'll be getting that if these populations from Freedom continue to be followed.
Dr. Coase?
So I wanted to thank the speakers and the panel for really an outstanding 2 days. There was an important, nuance or discrepancy from yesterday that I wanted to highlight to the panel, and that has to do with what was discussed about short-term therapy for 3 to 5 years. So in Dr. Rosen's talk, where he specifically focused on studies in patients with osteoporosis by bone density, i.e. a T-score less than -2.5, or previous osteoporotic fractures, he presented really very robust evidence that in those patients, the drugs that we have are really very effective in preventing fractures. That was different from what Dr. Vishwanathan presented in her evidence review. And I just want to make sure, because I spoke with her, I don't know if she's here, but that evidence review actually excluded patients with fractures. So it was a very different population from the population that Dr. Rosen talked about and the population that we're all concerned about. We're not going to be treating the patients from that evidence review. So as you deliberate over kind of the short-term findings, I think that's an important point kind of to keep in mind between those two presentations.
Thank you.
Question for Dr. Bauer. First, a comment, which is with regard to lumbar spine BMD, there are confounders for lumbar spine BMD from degenerative changes in aortic calcification, et cetera, that may explain why it's less valuable as a predictor or potential endpoint than hip BMD is. The question is whether you've had a chance to look yet across ages or other factors that might indicate whether or not there's a difference in the efficacy of BMD as a surrogate in different subgroups.
Great point. Every clinician in the room knows that the older you get, the less predictive spine BMD is because of the problems with artifact. Most of the trials included some younger individuals, so those types of age stratification should be possible, but we haven't done them yet. It's a very good point, though.
I've got a comment and a question. The comment relates to the media activity, which we've heard a lot about in using inappropriately graphic language about the side effects which may occur and frightening patients and doctors as a result of that. But the other very harmful effect they've had is, I think, encouraging the perception that doctors often can't be trusted, that they sit in the laps of pharmaceutical companies, and that their motives are not always the best. And I remember seeing some of the emails that came that Elizabeth and Sandeep got from patients, and that was a large part of it, a lack of trust in the physicians. And I'd be interested to hear what Ken and Paul have to say about that, and maybe also Debbie. So maybe I'll ask my question after the answer to that.
Juliet, it's critical. We're physicians. We take care of sick people. They come in scared. They're nervous. They don't know what's going to happen to them. They may not show that scared, but they're frightened. No one wants to go to the doctor's office. And I think that with all the pressure that we have on time, and people knocking on our doors because it's a little bit too much time, and I have to keep reminding all of my colleagues that our greatest job is holding a hand and looking into the eyes and getting trust. And I think the other comment that I would like to make is that if we ever lose humanism in medicine, we lose the profession.
So one of the things which has gotten in the way of the patient-physician relationship is the computer, which sits in the office of every healthcare provider who sees a patient who uses an electronic medical record. Now, the panel's all sitting in front of their laptops, okay? And when you see a patient, you sit in front of the computer and you're typing, and you're not really looking at the patient unless you learned how to touch type when you were in elementary school, which I fortunately did. So I can look at the patient and type my note as I interview the patient. But most younger people are actually looking at the screen, and they're not looking at the patient. So that interferes. The second we heard from Dr. Gill yesterday is they spend 20 minutes in a primary care appointment, right? So if you have the luxury in academic medicine or within the VA system to spend time with a patient, you can engender more trust because you can discuss things with the patient and you can enter into this whole principle of shared decision making. But in the community, the trust of physicians in the United States has plummeted probably to where we're around the level of Congress, the news media, or lawyers.
I want to just add to Mark's comment, and I think on the one hand there is some tendency to sort of brush this off as a societal problem and say we can't change the way people perceive the government, physicians, et cetera, but it seems to be preferentially affecting osteoporosis. And when you look at statins or PPIs, other drugs that have fairly serious side effects, they're going up. People are using more of those drugs. So I think there's two important groups that we really have to work with, and this conference has benefited by that input. And one is patients. We've got to have more patients in the dialogue, not just as recipients of the information, but as partners in developing the research. The other critical piece that many of us in this room, regrettably, are somewhat guilty of is we haven't had enough dialogue with our colleagues in primary care. It's been a little bit of a sound vacuum and an echo chamber around this dialogue in bone health, and some of the docs in the community feel like they've been sold a bad bag of goods with regard to bisphosphonate side effects and other things that we just simply didn't know about when we started using these drugs. So the NOF and other groups have really reached out, and I was delighted to see Dr. Gill here at this meeting. But we've got to engage our colleagues in primary care. They've got to be part of the dialogue. We've got to somehow work together better to get the messages out.
Okay, thank you. And my question, if I may, is to Doug. If you get finally BMD accepted as a surrogate for drug trials, what impact will that have on the number of people who would need to be involved, patients who would need to be involved, and B, the duration of the study. And going on from that, what impact is that going to have on collecting safety data? Because presumably the numbers will be reduced, the duration will be reduced, and we may therefore lose out on getting good safety data.
Right. Julie, you've hit the nail on the head, and I'll just make two quick observations. One is that the FDA requires shockingly little safety data now. So this won't change that. And I can't remember the exact amounts, but it's 200 or 300 people for 6 months in a randomized controlled trial for safety data. So it really is not going to change the fundamental issue that there are potentially long-term problems that need to be followed in long-term follow-up studies, either randomized controlled trials or other things. And the second issue, though, is that it does reduce the number of individuals and the duration of the trials dramatically. So if we were to use a BMD endpoint, we're talking about hundreds of participants for up to 2 years, perhaps even as early as 1 year in the change, as opposed to 3 to 5 years, depending on the fracture outcome. This is really heavily dependent on the opinions and preferences of the FDA and the other regulatory agencies in the world. So we are really in a new territory. And the fracture validation for surrogates is quite different, actually, from some of the other ones that have been approved, for example, for viral load, where there is really a strong understanding of the underlying biology. So this is going to be a brave new world for us, but we're anxious to see if it can move forward.
Thanks.
Hello, Joanne Pinkerton from the University of Virginia and the North American Menopause Society. A couple things. One, I just really wanted to say how much I appreciated the focus on efficacy and treatment for women 65 and over and this coalition for preventing the secondary fracture. But there were two groups that I want to make sure the panel thinks about. And one of those are those women who are really at severe risk for vertebral fracture that haven't yet fractured at whatever age, and that we have these newer anabolics, that this treatment might be the first therapy instead of always starting with a bisphosphonate first. So just the concept that, you know, the really high-risk women need to be treated a little bit differently. And second, this concept of prevention or treatment with hormone therapy. You know, the WHI answered some very important questions about what standard dose conjugated estrogen and medroxyprogesterone does and doesn't do, but it didn't really address the lower doses, the efficacy on the bone, the fact that we have transdermals, that we have newer progestins, we have ways of treating these hypoestrogenic women during that time from menopause to before they're 65 or even 65 and older for some of them with low-dose hormone therapy that may be an option so that we don't get to the point where they need to be on a bisphosphonate. So thank you.
Next.
Yes, so this question comes from one of our online viewers. And it's directed to Dr. Bauer. It seems most important for clinical...
Could you get a little closer to the mic?
Sure. Let me put it down for the short people here. It seems most important for clinical application to determine what proportion of fracture reduction is explained by changes in BMD and BTMs during therapy, rather than just determining whether they are correlated.
Okay, I'm not totally, I understand the question, but I think that is actually what the PTE analyses do. They provide a quantitative assessment of the proportion of the treatment effect that is explained by that marker. That is relatively straightforward, but there are a lot of nuances in terms of the actual methodology to calculate PTE and the confidence intervals around that. But what I'll say is the biggest problem here is how good is good enough. So if it's 70% PTE, is that good enough to move in surrogacy, or something higher, 80, 90%? So that's going to require an iterative interaction with the FDA, and I hope I've answered that person's question, and I appreciate them looking in online on us.
Thanks.
So I would like to make a comment that is at variance with some of the discussion that just happened in terms of blaming the press, et cetera, for some of our failures. And I do not believe that fear of the side effects of our effective drugs is a sufficient explanation for why patients are failing to take them. Patients take these very same drugs at the same or higher doses when prescribed by oncologists. What we are doing, or what we are not doing, is we are failing to convince patients of the benefits of therapy as opposed to what happens in that oncology setting. The patients know why they're taking the drug, they know how it's going to help them, and what we have not done effectively as a community is to communicate to patients what the benefit of therapy is in a way that they understand. So I don't think that it's just the fear of side effects. I think it's a failure to identify the benefit. It's not the risk side, it's the benefit side where we've failed.
Thanks, Rob. I think that there's first of all, the patient who's fractured, it's usually not a problem in terms of it's the people of the silent condition that have a bone density level and it hasn't fractured, that we're trying to convince that this is going to benefit them, and that's always a challenge. They want to deny that they have a condition that's associated with being old and frail, and that's a hard thing to jump over.
Even after the fracture, that's still hard because they say anyone would have fractured if they'd fallen the way I'd fallen. And we have really not communicated to them that they have a biological substrate that predisposes them to injury.
So in the Baltimore hip studies, I mailed the results of DEXA testing with a cover letter which summarized the NOF recommendations that everybody over 65 with a hip fracture should be treated for osteoporosis to all the primary care providers of all the subjects that enrolled in our study. It had no effect. So this was not directed to the patient, which maybe it should have been with implementation science had I consulted with my friend Ken before we did this, but it was to the provider, and it did not affect the providers at all. I think there's a difference between having a diagnosis of cancer where you're going to receive chemotherapy, radiation therapy, now immunotherapy, with no obstruction from the insurance company, by the way, on getting this funded. And if you don't get adequately treated, you're going to die, and you recognize that you're going to die, and your family recognizes that you're going to die. And you're being given a potent bisphosphonate to prevent the complications, either of androgen deprivation therapy if you have prostate cancer or multiple myeloma or metastatic disease, versus osteoporosis, where again, I think there's not as much recognition in the community among individuals that hip fractures kill people and vertebral fractures are associated with increased morbidity, increased mortality, increased risk for fractures. So there's been poor communication, but there's also been an emphasis on the rare adverse events of the drugs which scare people. I would suggest that if you had the same focus on necrotizing myositis with statin therapy, there would be a reduction in the number of people who are taking long-term statins for treatment of hyperlipidemia, where there's some, but not great evidence that you're going to be reducing myocardial infarction.
I think it's fair to say that this is probably multiple factors at play. Let me take one final question from the audience and then ask Dr. Bernard to come up.
Yeah, Art Santora, disclosed as a former Merck employee. Actually, this is another request, and that's that when I read some of these evidence-based presentations, I think they're very valuable. But there are times where I'm really confused about low evidence. And if there, I guess it's a situation where you say, there just isn't enough evidence to evaluate this question. If that could be disclosed, that would go a long way for me. And actually would apply to, say, non-vertebral fracture risk in a drug holiday. I'm pretty familiar with that data, and I will honestly admit, we don't really know. But I would say we just don't know the answer to that question. Thanks.
Fair enough. Thank you. Let me take this opportunity to thank this speaker panel and ask Marie Bernard to come up. Yes, thank you.
Good afternoon, everyone. My name is Lyndon Joseph, one of the co-planners, along with Dr. Faye Chen from NIAMS and Keisha Shropshire from ODP. And I would just like to thank all the speakers for all your dedication and your effort, and for putting up with all the emails from Faye and I about your abstract, your slides, your travel plans, and I really appreciate the effort you guys put in. I'd like to thank the panel in advance for the incredible task that you have at hand to synthesize this and put it together. I just want to thank you for your dedication as well. Thank everybody for hanging in there, and I really appreciate all the effort that has been gone into this. I would like to remind the people who are here and on the webcast to check the ODP website and respond to the EPC document for the open comment period. It's going to be open until November 27th, so I remind you guys to please comment and add your suggestions. And without further ado, I would like to introduce Dr. Murray Bernard. She is the Deputy Director of the National Institute on Aging, and she would give the closing remarks. Thank you.
Well, good afternoon, everyone. First of all, I'd like to thank you for the introduction, Lyndon, and for the amazing job you've done in working on this workshop. I'd also like to extend thanks to Dr. Faye Chen of the National Institute of Arthritis and Musculoskeletal and Skin Diseases, NIAMS, and Ms. Keisha Shropshire from the NIH Office of Disease Prevention, ODP, for all of the work, because it takes quite a bit of effort to bring together such a wonderful convening scientifically. I'd also like to extend thanks to NIAMS, ODP, and the other federal agencies that were responsible for sponsoring this workshop. This is really, as we all know, a very important topic. It's meaningful to me not only as a staff member at the National Institute on Aging, but as a geriatrician who over the last decade has been very distressed to see the decreased frequency with which treatment for osteoporosis has been offered to older adults. As has been well summarized, we've had a really good recap of short and long-term use of drugs for osteoporosis, drug holidays, patient and clinician factors that influence medication use and adherence. And there have been a lot of research gaps that have been identified. I personally was really struck by the frequency with which the Evidence-Based Practice Center said that the quality of the data was low or insufficient. So lots of opportunities for us. Kudos, Dr. Sue and panel members, for taking on this really monumental task. It's really going to be arduous, but I know that the stipend that we provide you from the government will more than compensate for all of this time. And we, the federal partners, will be in the next several months developing an action plan. I'd like to bring to your attention some examples, some additional examples of pertinent research. We've been talking about falls, and some allusion was made to the STRIDE study. The STRIDE study is a collaborative between PCORI, the Patient Centered Outcomes Research Institute, and NIH, NIA in particular taking the lead, that's doing a pragmatic trial of falls prevention in 10 different clinical sites involving 86 different primary care practices, focusing on 5,000 plus subjects who are 70 years of age and older. And the intent is to bring together all that we've learned over the years about falls prevention. The intent is to follow subjects for an average of at least 2 years, and they've recruited their subjects, the intervention is underway, and hopefully we'll have some results from that in a couple of years that can be applicable to considerations about osteoporotic fractures. And then, again, I recognize I'm preaching to the choir here. You're very familiar with the study of osteoporotic fractures, the study of more than 5,000 women, started in the 80s, followed for more than 25 years, that's really helped us to identify risk factors for fractures. And the Mr. Oz study, the study of osteoporotic fractures in men, again, 5,000 plus, started in 2000 to 2002 and still ongoing with follow-up. That's really helped us to understand some of the gaps in standard care for men relative to osteoporosis. And the reason I highlight them is that they're great examples of collaboratives across entities, at least here at NIH, that involved the National Institute on Aging, the National Institute of Arthritis and Musculoskeletal and Skin Disorders, the National Center for Advancement of Translational Science, the National Heart, Lung, and Blood Institute, and the NIH Roadmap. So there have been efforts in the past that have been collaborative federal efforts, and hopefully we'll see more in the future. So again, as Lyndon said, as many have said, we really thank the ARC Evidence-Based Practice Center for very thorough evaluation of the data. We thank you, the independent panel, the speakers, and all the participants, and we really look forward to the outcomes of all of this and what we will get to do in the future. So, thanks to all.
And let me just make a few closing comments before we end today. Many thanks have been proffered. Let me just thank my panelists in advance, for the work that you will be working on over the next couple days, and probably weeks, in terms of finalizing this report. A special thanks to all of the speakers. You have managed, to stay more or less, within our time limits, and that actually allowed us to get to the end, and to hear from the speakers at the end of this conference, in a meaningful way. So special thanks to all of you, for doing that. And I have to tell you, that as a geriatrician, it is particularly gratifying to me, to hear a nephrologist, Dr. Miller, talk about, and being the greatest advocate that I've heard in terms of, of looking and observing at patients, getting up from a chair, in the context of an office visit. So thank you, Dr. Miller, for sharing that anecdote, at least with me. And finally, a special thanks to the staff, who really have pulled this off, over the last day and a half. A special thanks to Keisha Shropshire, who has, been the manager, of the panelists, and many aspects of this day and a half. We probably could not have done this without you. Thank you all.